learn from each other. But before we get started, anything that's coming up from yesterday that we need to resolve before we jump into today? Everybody feeling good?
It was a great day.
Was it a great day?
Yeah.
All right, perfect. That's all we want to hear. Thank you, Lee. No, just kidding. Any other questions or thoughts before we can get ready to go? No? We're good?
Well, at some point today, are we going to talk about what's coming next or what the future's in store?
Yes, we will. What I do want to say, though, is given the time crunch that we're on, we might end up doing a lot of that. It could be after an upcoming webinar or some other discussion, because we really want to make sure we utilize the time that we have here. And so I think that with transfers being late a little bit here and there, we kind of lost a little time. So we really want to maximize the time with everyone here. But we will talk a little bit further about next steps, structure, where we're going as a group and as a program. It's definitely on the docket. And a little bit of, we're waiting for some funding stuff to come through and getting a little bit of, kind of getting a real grasp on what that's going to be looking like coming forward. But yes, Sharon and I have chatted that we definitely want to spend some time with all of you kind of talking about next steps as RACs as a whole. So, okay, so I will have you introduce yourself, and I just think the one thing I just want to say about this gentleman is I think that what University of Wisconsin has done in terms of looking at screening and then making inroads for the work that you're doing with the CT colonoscopy is outstanding. It's really exciting to really have the people who are really working in these technologies the opportunity to really interface with us. So thank you so much. We're really excited.
Okay.
So, okay.
Thank you. So my name is David Kim. I'm a professor here at UW, and my area of research is in CT colonography, which is a screening modality that we'll talk about, and in PET-MR, which is a sort of a newer imaging examination test that really is showing some interesting potential and helping us to manage colorectal cancer and staging and what have you. So once again, thank you. I hope this information will help you in your advocacy, because what you guys do is so important. I've seen firsthand the impact and the changes you've made because you put in the time and effort, and so I just really thank you for this, and hopefully this lecture will help in those efforts. So we're going to spend a lot of time, or the majority of the time, on CT colonography. We'll talk about exactly what is this test. We'll look at sort of the timeline and how it evolved from a research sort of tool to now it's kind of translated into clinical use. We'll look at the attributes of the screening test, and then some of the efforts that what's happened at UW. And then we'll look at a second test to finish up, looking at PET-MR and its applications in sort of cancer staging and management. So starting first with CT colonography. It's also known as virtual colonoscopy. People use the terms pretty interchangeably, but CT colonography is a formal term used in the literature. Simply put, it is a low-dose, non-contrast CT. So nothing huge or special about it. It's something that you can do on any CT scanner. But in addition to that CT scan, there is a specialized protocol. So the person undergoes a bowel preparation. That means that we clean out the colon with catharsis. We give you extra material that sort of tags any residual kind of fluid or material in your colon. We then, when you're on the scanner, extend the colon with low pressure continuous carbon dioxide. So this is sort of the picture of the CO2 insufflator, and this is just your standard 16 or 64 slice scanner. We scan the person once on their back and then again on their stomach, so this creates two data sets, and sometimes we need to scan a person the third time with them on their side. And this creates a number of sort of images, both from a 2D perspective and a 3D perspective, and we use all of those, and this is sort of the images we get to help us determine whether or not a person has a colorectal polyp or colorectal cancer. And so here's a sort of a typical example. So a 57-year-old male, screening, healthy, asymptomatic. This is the computer-generated insufflation of the colon, and in the proximal rectum, when we went through it, we noted this, and this is what it looked like on the endoluminal view. So this is the end of the rectal catheter that's infusing the CO2. And as we start the fly through, you can see that in the proximal rectum, there's this dome-shaped structure that looks suspicious for a colorectal polyp. Now, once we see it, and this is something called translucency rendering, it gives us a sense of sort of the internal characteristics. Red means soft tissue. Once we see something that potentially is a polyp, we then turn to the source images, and you can see that it looks very much like your standard CT. This is the person's acetabula, it's part of the pelvic bone. This is the sacrum that goes down to the coccyx. So this is the front of the patient, this is the back of the patient. And when you look at a CT scan, what you can imagine is we're cutting the person kind of in cross-section, and then it's like you're looking at the section from the person's feet up to their head. So the right side of the person is going to be on this side of the image. The left side of the person is going to be on this is the image, this is the back, and that's the front. And you're looking up through the feet toward the head. And so what we do is when we see something on the 3D view that potentially is a polyp, we look at the source images, again with the person on their stomach, and then again on their back and then stomach. The image on the stomach is here. And we see if this candidate fulfills certain criteria. And this one does. It basically has a gray soft tissue core. It's fixed in position along the posterior wall of the proximal rectum here. If this was a piece of stool, this would fall to a dependent location with gravity to this part of the colon. And because it remains along that posterior wall, we know it's real. Once it's real, we have an integrated program with colonoscopy. We send them to colonoscopy that afternoon, so there's no additional prep. The person goes on. At colonoscopy, this is removed, and this turned out to be a tubulobillous adenoma. So this is sort of what we're trying to do with screening. We're trying to find that benign polyp, but it has the marker that perhaps a decade down the line, it would turn into a rectal cancer. And by removing it, we've prevented the person from developing cancer. In sort of the research realms, we've recently recognized there's a second way to cancer besides adenomatous polyps, and those are sepsis-related polyps. And these are lesions that are more subtle, but we can see them. And there's one right here. And you can see that when we send this person on a colonoscopy, how subtle this is. It's this pinkish flat thing. This is normal sort of mucosa of the colon. And so this technology can see this newly described precursor to cancer, which is really good. It's a minor pathway to cancer that, probably, a good 7-10 years ago, we did not recognize the significance of these lesions. And now that we know about them, we're trying to find ways to improve our detection of them so we can remove them as well. So, when we talk about device development in imaging, a rule of thumb is it takes about 17 years to go from research into clinical use. For CTC, we're a little bit further out. We're at 21 years, but it really is fairly entrenched in clinical use now. And so it's sort of following that. It's been delayed a little bit, unfortunately, due to some reimbursement issues. So Dave Biden, back in 1994, sort of kind of presented this at the Society of Gastrointestinal Radiology meeting. And that sort of kind of spearheaded and sparked the effort in the research realm. Feasibility studies occurred a little bit later, sort of proof of concept studies. Could CTC detect polyps? And these are two of the major papers of that time. And this is sort of the easiest case scenario. We looked at CTC in high-risk patients, so we knew that most of the exams would be positive, and when they were positive for polyps, there were multiple polyps. So it was sort of the easiest case scenario to look for polyps. And once we saw the performance of CTC in this cohort, we knew that it potentially could be used in the population that it really should be, and that's screening, where most of the exams are going to be negative, and so can you sort of maintain good performance when the majority of them are not going to have a polyp, a large polyp anyways. And so there were 3 multi-center trials at that time. Perry Pickard was with the Department of Defense. He is now at UW, and he led a pivotal trial. And then Cott and Rocky were the 2 others. Now, unfortunately, when these 3 came out, there were discrepant results. The DoD trial showed excellent results that indeed you could use CTC in screening. cotton rocket showed very poor sensitivities for polyps, large polyps, somewhere in the order of 50% sensitivity. And so there was a lot of sort of debate and controversy on whether you could use CTC. And that was laid to rest with the National CT Colonography trial led by Dan Johnson out of Mayo in 2008. This was a multi-center trial, 15 institutions involved, a little over 2,500 screening individuals, and used sort of the latest techniques for CTC and used colonoscopy with something called segmental unblinding, which isn't super important, but used colonoscopy as the reference standard. And what they found was that the prevalence of polyps, large polyps, was 4%. And so that is an interesting number. So if you set your threshold at removing everything that's 10 millimeters or larger, and at this size, polyps are unlikely to regress, you can see that you can make, it's not a huge number where most of the people are going to be positive, but you can make a big difference in subsequent cancers. So in terms of sensitivity, it hit a 90% threshold at the 10 millimeter size threshold. It dropped down to close to 80 at 6 millimeters, and the specificities were kind of in the mid to high 80s. But these numbers were felt to make that threshold to say, yeah, you know, the performance of CTC can be used for screening CTC. So it kind of paved the way then for inclusion in various guidelines, and it also sort of put to rest this debate. So back in 2008, American Cancer Society adopted CTC within its guidelines. This paper came out just as the USPSTF guidelines were coming out. They did not include it in their analysis. It took this paper as well as additional sort of research, and now it's in the USPSTF guidelines for 2016. And so here are the two guidelines, American Cancer Society. It splits screening tests into those tests that look at polyps and cancers versus those that just detect cancers. And ACS says that if you have the choice, you want to put in the first list, and CTC is on that list. For USPSTF, screening gets an A rating. That's their highest rating for anyone that's between 50 and 75 years of age. They give a list of recommended screening tests that you can do, and CT colonoscopy has now made that list. And I can say that this acceptance by USPSTF was helped by the advocacy from Fight CRC. Patient advocacy helped along, you know, there were, when the initial preliminary draft came out, CTC was not on this list. They gave the reasons why they didn't believe it should make the list. There was a huge sort of response in the public comments that included patient advocacy, researchers, various societies, and it was that push that changed things. Yes.
Basically looking at screening age, why is it, does it list African Americans who tested at 45? That's the standard.
Yeah, so this is a very sort of conservative guideline, and they're evidence-based. So what they did is they looked at a systematic review of the evidence, and in those areas where there was not enough evidence to support a guideline, they did computer modeling through 3 different sort of groups that came together to form this systematic modeling. And in their modeling, it didn't meet certain thresholds, so they didn't include it. But I agree with you that there is a lot of concern and effort that, you know, that colorectal cancer is more prevalent in African Americans, and, you know, we need to improve screening and think about going to a lower sort of or earlier starting ages. But unfortunately, it didn't meet their sort of computer models, and so they didn't put it as a sort of.
Is the bowel prep the same for CTC as colonoscopy, or is it?
It's slightly different.
Because that's the bad part of colonoscopy. The colonoscopy itself is not.
So there are different sort of bowel preps for colonoscopy. You can do PEG, polyethylene glycol, which is like 4 liters of this watery solution. You can do an osmotic cathartic based on magnesium citrate that basically pulls water into your colon in kind of a very salty solution. So that part is the same in the sense that we do use magnesium citrate as opposed to polyethylene glycol, which I think is, I've had both, and the mag citrate is much easier. And then we give you other things that tag any residual materials, but those are pretty palatable.
And in terms of overall cost, I mean, obviously, if someone does have polyps and has to have CTC and then colonoscopy, it's more expensive, but only 4% of people need that. So over the entire population, it's less expensive to screen people first with it, with CTC, and then if they need it, go to colonoscopy and avoid those colonoscopies for.
Yes, and that is a crucial point, that, you know, people say, well, you're doing 2 tests, it's gonna be more expensive, but the kicker is that the majority do not go on to 2 tests. And what our experience has been since 2004, about 10% of people ultimately end up with colonoscopy. 4% have the big polyps, but there are some people that are unwilling to tolerate the anxiety of a polyp that's like 7 millimeters, and they feel like it might turn into cancer, and those people just want to go. If they feel that way, we say you should definitely go. Although I don't think they take into the account the true risk of colonoscopy that you need to balance with that.
Let's go ahead and then, Dr. Kim, don't let me forget about the USPSTF and the CISNET recommendations, because I want to let the group know about something that we're working on. Go ahead.
So, I'm glad to hear this morning, because I've heard nothing but bad things about this for a long time, that this really wasn't detecting. But what I'm not sure if I see it, and there's a lot of small print up there, but what is the recommendation to use this for us survivors, for our first 3 or 4 colonoscopies that we do every year? Do they have no problem with us doing this?
So there are currently the recommendations for cancer and then subsequent surveillance for subsequent lesions, metachronous lesions. CTC is not incorporated into that currently.
Okay.
There is a multi-center trial that has Memorial Sloan Kettering, Fox Chase, Mayo, University of Chicago, and us that have looked at a cohort of people 1 year out and surveilling with CTC versus colonoscopy. And those results, so that trial's ended and we're looking at the results right now. And it's interesting. I can't say the results, but
Okay. Interesting.
So, Dr. Kim, you mentioned, so the USPSTF, these being the guidelines that are talking about basic recommendations for population-based screening. And then when Fight CRC, when we went through this list, when they made the initial recommendations, we worked with the medical advisory group, had it out for public comment, and then we responded to every single piece, talking a little bit about what our perspective and the things that we felt needed further recommendation or discussion. And so one of those, and I know that this is part of part of the mission of this organization, is really looking at particularly the under 50 phenomenon in terms of looking at increase in incidence at younger age and the like. And so we are working right now in preliminary discussions with American Cancer Society, Memorial Sloan Kettering with Ann Zauber, and then Rocky, I can't remember his last name, out of NCI. And so we are really looking at hopefully being able to use what Dr. Kim talked about is the CISNET modeling. And so in the absence of being able to utilize trials for certain groups and subsets to look at recommendations, we are going to hopefully use the CISNET modeling to go back in and examine the under 50 criteria, specifically for African American and Native American populations to start, and then hopefully being able to look further at that sort of modeling study at the under 50 at large. So we're really excited because I think Fight CRC has been really thinking actively, how do we get engaged? So we're part of consortiums for the under 50 with Dr. Weber, we're under with a lot of the other consortiums. But I think for a dedicated research lift, we're really looking at this CISNET modeling to help really actually go back in and really take an examination to look at this criteria again to see if we really can see more. So by the time that the next USPSTF guideline is up, that we've really kind of taken a critical look with the same modeling that's been effective and done well. But we really want to go back with those same people who've been working with the same, for 20 years to make sure that we're really there. So next week, we're actually entering into a discussion about that. So that's where Fight CRC is really putting some dedicated resources. So we're really excited about it. Yeah.
So besides USPSTF, so I think the next sort of area that's sort of related is reimbursement by CMS. And so, hopefully the scientific community, patient advocacy can come together and get this reimbursed. American College of Radiology, we just put in for an NCD through CMS to reimburse it. So it's in the works right now, and I'm sure there's going to be time for public comment.
Right now, what is the cost of a CTC as a patient coming in versus a colonoscopy?
So
we just need one.
Yeah, so, people talk about Medicare costs, which to me really aren't the true costs. They're so much lower than what it is. But I can tell you, like a UW, a CTC will be like $1,200. Colonoscopy would be like $3,000 before the biopsy. So it's about half to a third the cost of.
So it is a lot cheaper.
Yeah, because a CTC it's just a CT scan. There's no patient monitoring for sedation and no holding recovery or anything like that. So
Yeah.
that's why it's so much cheaper.
But you have to have two CTC scans to one colonoscopy. It says 5 years versus 10 years.
Right.
Then right.
You know.
So that plus the positive patients that need to get removed end up with 2 tests as well. And so there are various cost effectiveness analysis that have looked at, the offsets between that, which is cheaper. And there's a good body of literature that says that CTC-based screening would be cheaper. There is literature that says the reverse. And unfortunately, when you look at cost analysis studies, it all depends on the inputs. And so you need to look at those studies and look critically, does it make sense, like the costs they're inputting in, the assumptions they make of how many people need to go, what is the sensitivity of the test. If those assumptions, when you look at their list, make sense, then you should probably put a little bit more stock in that study versus the other. So there's a little bit of conflicting data, but I think it just, to me, and
Well, it's
obviously I'm
less
very biased,
invasive,
but
correct?
I think it's cheaper.
It's less invasive, so, you have less risks. I mean, there's cost benefits to things like that.
Yeah.
It's from, you can't say it's a third or half the cost typically.
Yeah, definitely.
So to clarify, you would do the CT, and then if they find a polyp, they still have to go and do a colonoscopy to remove it.
Yes.
It's the procedure.
If it meets criteria, if it's a centimeter in size or not, or centimeters in size or greater. If it's less than that, we would give you the choice of imaging surveillance, where you wouldn't have to go through it, right, just monitor. So so we've screened now about 12,000 patients. Our rate of going on to colonoscopy is 8%.
And there's a reason it's every 5 years, because it's not as able to find polyps as the colonoscopy.
So that is a great question too. The reason why is we set a lower threshold of what we call positive at 5 millimeter or 6 millimeters, and we call 6 millimeter anything less, well, we say 5 millimeters or less. We do not report. So if we see what is called a diminutive polyp, very small polyp, just a couple of millimeters, we do not call that. And the reason why is that many people in the population have polyps that size. Those polyps, the ones that turn into cancer, just grow. They don't turn into cancer then. More likely than not, what they do is they just grow over time. And so by setting a lower threshold and you ignore those polyps that are tiny, where 98% of them will never turn into cancer, you decrease all the resources to removing things that make no difference to you, right? So if you remove 30 polyps, but those 30 polyps had no chance of turning into cancer, you haven't done any good. It's just put people at risk with polypectomy.
And a colonoscopy would remove
We
those?
remove all of those. So that's why sometimes you say, we remove like 15 polyps, but if you look at the size, they're all like 3 or 4 millimeters. The reason why is because you don't know at that time point which one's going to go on to cancer. What we would argue is the ones that go on to cancer, grow over time, but they don't turn into cancer. And if you see them growing and they get larger, then you take them out. But a lot of them don't grow. They either stay the same or they regress in size. And by doing that, you decrease the number of polypectomies, but you don't decrease the cancer prevention aspect of the test. Okay, so screening test attributes, we've sort of gone over it. So one, it's very safe. There's no risk of perforation. Colonoscopy, the risk is somewhere about 1 in every 1,000 people will get perforated. If you get perforated, it's a colon resection, and there's definite, problems with that. With CTC, the risk is something like 3 in 100,000, so it's 1 in 30,000 or so. So it's almost 2 orders of magnitude less than colonoscopy. It's a very safe test. It's basically just a CT scan. It's effective. It has a high sensitivity for cancer. All the screening tests do, but it has that possibility of preventing cancer by detecting polyps. And we've kind of gone over this, but this hopefully will add to your knowledge and help you understand why screening is so effective for colorectal cancer. So, we have this benign lesion we call the colorectal polyp, and it accumulates genetic abnormalities over time, and at some point turns into cancer. So if we screen and remove this, we've disrupted that pathway to turn into cancer. And that window we have is not like weeks, it's not months, it's not a year, it's like a decade. So we just need to get people screening to see if they have a large polyp and pull it out before it turns into cancer. If we miss that point, it turns into cancer, we still have a second window where if we screen before the person gets symptomatic and says, oh, something's wrong, there's better outcomes. So if you think about screening for breast cancer, screening for prostate cancer, this is where those screening tests work. You detect an early cancer before you're aware of it. For colon cancer, why screening is just so vitally important is that it works here, but it also works in this window, which has a huge effect of preventing cancer. And so when you look at the screening test, stool studies only work here, looking at early cancers. Colonoscopy works at both levels, and that's why it's so much more effective, but then it's offset by the potential risks. CTC works at both levels and is safer in terms of perforation. Just a couple more comments about this key concept. So, we talk about colorectal polyps, but really, when you look under the microscope and look at the pathology, it's only adenomas that can go on to cancer. And of the adenomas, only a tiny minority do. The vast majority do not. So if you think about what the rates are in the population, anywhere from 25 to 45% of the population will have an adenomatous polyp. Obviously, that's not how much of the population that comes down with cancer. So we know that adenomas regress and get smaller. So we need those strategies like ignoring adenomas by size criteria and waiting for them to show uniform growth. Recently, we've realized that there's a second pathway to cancer through serrated lesions, and the specific names aren't really important. But there's a minor pathway, about 15% of people have these types of polyps that can go on to cancer. So this was a study that we did at UW because we had sort of this ability, we had this unique situation where we had a CTC-based screening program, optical colonoscopy-based program. We said, well, we have different strategies. They take out all the polyps they see. We kind of ignore most of them and just focus on the ones that we think are going to turn into cancer. What happened? Like, what is the yield of the significant lesions versus the complications? And so this group, these two cohorts were drawn from the same area, from the same group of referring physicians. We looked at advanced neoplasia. So this is a measure of, this is what we want to remove, compared against the number of polypectomies to get there, the number of complications. Because again, colonoscopy, anything you see, you take out. CTC, it has to be a certain size before we'll even call it, and then a certain size before we would recommend it needs to come out. So when you looked at the groups, they were matched in various sort of categories, and what we saw was that the output was the same between the two groups. So there was no statistical difference in the yield of important lesions. But to get there, there was a huge difference. They did 2,400 polypectomies. We did a little over 500. And then this ultimately led to 7 perforations versus 0 in our patient cohort. And so this kind of, I think, is a good study that shows the value of doing CTC-based screening. And it caused, it was, we did a lot of outreach during that time, and it ultimately got picked up by Saturday Night Live and was kind of fun fun.
A new study of virtual colonoscopy reveals that the experimental technique is just as effective as the more invasive method. The hard part is getting a computer in your butt.
How excited were you when that happened? Saturday Night Live's making fun of you. That's what you know. That's you made it. That's awesome.
So I'm questioning, the difference between this and a regular CT scan is the prep, correct?
Yes, and the fact that we distend the colon with carbon dioxide.
So without the prep and with the dioxide, you can't see. What's the purpose of a regular CT scan is my confusion. If you don't.
So without the prep, you have all the stool that obscures the polyps within the colon on a regular CT scan. And so regular CT scan, I mean, this is a CT scan, but it's just been optimized so we can see polyps. Without it, because you have stool that's in there, you can't tell the difference between stool and
Right, so what's the point? If you're going in and getting, I've been getting CT scans for the last couple of years, which makes perfect sense. They can't see because of the stool I haven't, cleaned out. What's the point of even having if you really can't see what you need to see?
They're looking at other organs.
They're looking at like liver,
Your liver.
Yeah.
lymph nodes outside of the colon. So the CT scan, not CT colonography, but a standard CT scan, is to look for things outside of the colon. So is something in your liver, is something in the lymph nodes, in your abdomen.
So this is to look at everything,
Checking to see if it's
or only the colon and not the liver.
So it's optimized to look at the colon, and without IV contrast, without increasing the amount of radiation back to a normal dose of CT, because this is about a little half to a third of the dose of a regular CT. The sensitivity is decreased for looking at the liver and other.
A little bit, it's getting there. So you still would have to do both.
Yes.
Question over here, sorry.
Oh.
Sorry.
Another thing, I'm not sure if I saw on that list you had up a few slides ago. So if someone, like the family, has Lynch syndrome, or in my case, pretty much everybody on my dad's side has had it, would you recommend going straight to just a colonoscopy versus?
So currently, this is for average risk,
Okay.
or, although with family history, we believe, or people called blood positive, we believe that this is appropriate test, but, so slightly increased risk from average risk. But for those people that have high risk, Lynch syndrome, Crohn's disease, they should go straight to colonoscopy.
Okay.
Yeah, definitely.
Conversely, since mine is not genetic, would this be an option for my family members who, wouldn't be considered high risk but need to be screened anyway?
Yes.
Also, is it a viable option for a patient who has a diversion, like an ileostomy or something?
Oh, for a different, we haven't done many patients with that. We've done patients with ileocolonic anastomosis, so partial colon resection.
Mhm.
We can do that. There was some concern at the beginning whether we'd be able to distend the colon
Right.
without an ileocecal valve in place.
Mhm.
But there's a nice paper out of Korea, Sungho Park, that showed that you can really distend the colon even with loss of the ileocecal valve. With the diversion, where that we haven't done, I don't know for sure.
Okay.
Yeah.
It's interesting, 'cause I have a diversion too, so that was a good question. I don't know why I
It's a great
didn't think of
question. So a couple more attributes. We do use ionizing radiation, but it's a fraction of a regular CT. And I just want to touch upon that because questions about that always arise. And then also talk about the fact that, because it is sort of a limited CT scan, you can see things outside the colon, what that means. So in terms of radiation, really at these doses, it's sensationalized and really shouldn't be a concern. The dose, and I'll explain what 3 millisieverts really means in practical terms in a second, but it's at 3 millisieverts. It's standard CT, now probably more like 8, 10 millisieverts currently. But all that's going down with newer sort of advances in CT technology. When we talk about 3 millisieverts per exam at these levels, this is a theoretic concern. There's no data that supports this. This is based on a mathematical model. And where this mathematical model comes from is World War II. So they looked at the population that was bombed. And when you look at really high doses, this is not medical imaging doses. This is super high doses. There is a linear correlation as you increase the dose, you increase future cancers. But where are we for medical imaging, and specifically for CTC? We are right here at this blue dot. So a best fit line of super, super high doses, when you backward extrapolate down to doses that we use at medical imaging, just crosses above 0. So people say there is a risk, but we just can't see it. Realize that 37,000 people from where this line was generated got a dose of 5 millisieverts or less, and they didn't see any cancers. People say there's too many confounding variables and you need larger populations. So there are larger populations that we've looked at, and one of them is the nuclear industry workers. So this was looking at 174,000 people, and when you look at their dose exposure over time, it would be like you getting a CTC for screening every 5 years between 50 and 75. So very similar doses, and there were no excess cancers. We've looked at airline pilots. Again, they get very similar sort of levels of radiation during their sort of job flying up high. And looking at fairly large cohorts over even 5 decades, there's been no increase in solid cancers. And so, this really unfortunately has been, like, it's scary because it's an unknown and you can't, people say, well, you just can't know. But, to put it into perspective, when you look at living in DC versus Denver and how much radiation you get from living, right? So this is cosmic rays, this is radon, your exposure. You get 3 millisieverts a year living in Denver, DC, 13 millisieverts living in Denver. So that if you're worried about getting a CTC scan every 5 years between 50 and 75, then you should be worried about living in Denver, because it's like getting 3 CTC scans every year if your life are there, as opposed to living in DC. So hopefully that kind of puts into perspective, because if you look at the cancer rates in Denver, who do you think has lower cancer rates? It's Denver. Yeah. So, there's so much about low-level ionizing radiation we don't know about, their DNA repair mechanisms and stuff like that. So we just don't know what's happening at those very low levels.
This might be outside of your realm of specialization, but many of us have gotten a lot of CAT scans, regular CAT scans, for our checkups through a number of years. So how concerned should we be with, chest, abdomen, pelvis? Now I know that's 3 times as much as just one area, or not, but I've always had chest, abdomen, pelvis, and I can't count the number of times I've had them, 20?
So, the good thing is, especially in the last 10 years, or so, people have been really dose conscious. So, like 15 years ago or so, we probably were getting, with a standard CT, maybe 25 millisieverts, which, health physicists, so these are their national society, their position is, you cannot make any, we don't know, you can't make any quantification of risk for anything less than 50 millisieverts. There's a chance that there's no effect at all. We just don't know. So if you look at CT scanning currently, you're probably getting more like 10 millisieverts, and really, it's something I would not worry about, especially because we're all adults. If you were a kid, I would definitely worry about it, because kids are very radiosensitive, and there could be long-term effects. For adults that are done growing and we're at 50, if this was to induce a cancer, you're going to see it like 25, 30 years from now, if that risk even existed. But you know, I wonder if that.
Thank goodness for old age.
And the importance of catching a recurrence is
So much
vastly
bigger.
much higher risk than the chance of the radiation exposure effect.
That's why they do it, and that's why we get it done, but I'm just.
And it's this fear that, you know, some people would forego that, you know, thinking, well, maybe I'm being smarter by trying to limit my CT scans, and that's why the imaging community is really pushing hard to say, you know, it's so much more important to get imaged, and don't worry about that other concern, because it's really, you know, the differences are great.
I've heard about, you know, monitoring the amount of radiation you get over a lifetime. There's a lifetime max.
Yeah, I mean, again, I think there's a lot of debate and controversy.
Okay.
What we'd like to do is minimize as much as we can and be smart about it, but not jeopardize answering the question.
So does anybody really monitor that? Is anybody like keeping track of how many?
Currently not in the United States.
Okay,
Yeah.
so don't worry about it. Okay, great.
Are you referring to the 50 to 75 population, and their access to the radiation, and it's being fine because of that age set? But what about us that are under 50, and we're starting to get this radiation a lot at an earlier age? What is the effects of that, and how do you compare the two?
So we haven't, but I guess the doses are so low that it's hard without huge populations to know for certain. But you know, the risk that people talk about where they give a specific number saying you get this much radiation, there's 1 in 1,000 induced cancers. That is a guess based on a mathematical model, which probably may not be true, maybe, you know. And so unfortunately, there's problems to quantifying risk at low levels because we just don't know what's happening. It may not have any effect. It may actually improve things a little because of, you know, there are theories out there called hormesis where low levels of radiation stimulate repair mechanisms and it helps fight off against cancer. So we just don't know. The data is just not out there right now. Okay, I'm gonna try to I feel really bad for Mike, sorry.
Question.
Oh, it's okay.
Okay.
You need to move on.
And then just quickly, you know, this is a CT, kind of a form of a CT scan. People have said, oh, you're going to find a lot of things that don't matter, drive up costs, create complications. Realize it's balanced by things that do matter. We do see extracranial cancers, we see aortic aneurysms, and so we just have to be judicious on what we call. In terms of the burden, people say, well, you know, you find things outside the colon 60 to 70% of the time. But that number is kind of misleading because if you find something, you don't necessarily have to work it out, right? If we see a renal stone on CT colonography, you have the diagnosis, you don't do any extra work out. It's just knowledge now, and it's a benefit. If you have right-sided flank pain, you know the cause, whereas before you didn't. So the better number is the ones that we say what need to be worked up, and when you look at those numbers, it's right around 10%. And then if you do a careful chart review, that decreases in series after series less than 10%, because you know there are reasons why you just don't work things up, and it's been estimated at various studies to increase the cost of CTC about $24 to $34 per exam, and that's balanced against the benefit. The benefit is extracranial cancers, lymphoma, renal cell are two of the major ones, and aortic aneurysms. And so what we've seen is that for every 250 people we screen, we see a cancer that they didn't know they had, either lymphoma or renal cell, again, are the two major ones. And then, the other line is about aortic aneurysms that's going to be kind of obscured by this picture, but we see out of every 200 patients in our patient population, we see an unsuspected aortic aneurysm. So this is from the CTC scan. This said we need to do a diagnostic scan. So this is a really big aorta. You know, it should only be about this big right here. And so this person didn't know they had it. And so there's a good chance that if we didn't know it when it first presented, it would have ruptured and likely killed the person. Instead, we could treat this. This person got a stent graft and is doing great. And so realize when we do CTC, we're also screening for abdominal aortic aneurysm because it is a CT scan. So So in terms of UW, we use it as a research tool, and one of the things we can do is look at the longitudinal assessment of polyps. We're now looking at sort of the genetic makeups of the polyps to see what is the difference between those that grow and are on the pathway to cancer versus those that are shrinking. This led to a number of publications and textbooks. And so this is a nice paper that Perry did that shows us following, and you can see what we see is about a quarter of the polyps get bigger over time, and then we can remove it. And then about 50% of the time they're stable, and 25% of the time they get small and regress. And so you can see here's a polyp right here. We see them back the next year, it's the same, and then 5 years or 2 years. And then 5 years later, it completely regress. So this is proof that polyp regression occurs. People have tried to do this with colonoscopy, but they were never sure if they just missed the polyp, and that's why it regressed. With CTC, there's no doubt, because you can see the colon in relationship to the extracolonic environment and look at every slice. And so this is a great technology for that. Things we're looking at, there's so much data in this scan, so we can look for osteoporosis, looking at ROI measurements, and so all at one sitting, you can screen for colon cancer, you can screen for abdominal aortic aneurysms, osteoporosis. There's work into looking at hepatic steatosis. So off the same exam, we can see whether or not you have significant fatty infiltration of the liver. We have worked with Ron Summers from the NIH looking at computerized segmentation of visceral fat, and that gives you a sense of metabolic syndrome, and so that's sort of an important topic that is kind of gaining more notice. And then, we're looking at how to improve sort of the way we look at images. This is a company that looks at using hands in 3D space to manipulate both 2D and 3D environments. And so this is something they were doing with TSA screening. So you can see the 3D model that you can look at, and then the 2D images, and we've applied it to CTC. And so we're approaching the person's colon. We're inside the colon. There's the ileocecal valve. They're kind of marching up the ascending colon, turning around, and as we look in the cecal, there's a mass right here that's kind of pinching into the cecal apex. We can combine the 2D images with that, so that's a cut plane that he's going to switch over to the 2D model, and what we're seeing that represents the mass is actually a big dilated tubular structure coming off the end of the cecum, and it's a penicil mucosal, so he's just kind of showing the 2D sort of pictures with that. So kind of fun things. I don't know where this is going to go, if this goes anywhere, but different ways of kind of interacting with the computer as well. And then clinically, it's firmly established at UW. We do it by a team approach. That's Holly, our nurse coordinator. We have people working with the database, the technologists that get the exam, and then we have a group of physicians that interpret it. And we screened about 11,000 patients, accounts for about 10% of screening. And what we've seen is that as a program has been in place, that screening optical colonoscopy has increased. And what we believe is that this option starts the dialogue for people that are unwilling to get screened, and then they get screened by either CTC or optical colonoscopy. And both are good measures. Just quickly about PETMR. So this is more of a research modality, and what we're doing, it's really exciting. We are combining MR, the anatomic information of MR, with the metabolic data from PET. So this is our integrated scanner. This is our MR scanner. This is the lutein PET insert. And so this is going to go into this part of the machine, and you'll be able to get both exams at the same time. And so what there are a huge number of uses in colorectal cancer. For initial staging, I think the main thing here is improving our accuracy in lymph node determination. And so we can use MR contrast agents. The one that people are looking into now is something called Faraheen. We can look at molecular targets through PET imaging other than FDG to help us improve our specificity and overall accuracy for lymph node detection. We're looking at it to see whether or not we can determine complete response to neoadjuvant radiation. So if you have locally advanced rectal cancer, if we can determine by imaging that you've responded completely, is there a role not to have to go on to surgical resection and you could just watch? And then with the new immunotherapy agents and the newer chemotherapeutic agents, the way response looks is different than we typically see. Lesions can get bigger, and that's actually responding, and hopefully information from PET-MR will help us in this determination.
Briefly, how is MR different from CT?
So MR uses magnetic fields to create images. CT uses ionizing radiation. They have differences in spatial and contrast resolution. And one of the benefits of MR over CT, so this image is a CT image, and this is the region of the rectum, and then here it is on the MR. You have much more improved contrast resolution with MR. So you have exquisite anatomic details. This is the rectal mass in this person. And then looking at it from a sagittal approach, again, here is that mass. And what we're doing is we're using the benefits of MR, the structural sort of anatomic information, melding it with the metabolic information for PET. So PET uses typically a glucose analog. So you can see this person's brain is really using a lot of glucose, and that's why it's so bright. And then also the tumor in this patient is using glucose, and that's why we can see it. So we meld the two. And this is one patient that after neoadjuvant chemoradiation, we looked at, you can see this is a person's rectum, and this is kind of thickened, and there's kind of a bulging out here. And then on the PET study, fused images, you can see that there's a lot of metabolic activity. So hopefully, images like this will help improve our sort of accuracy. So in summary, CTC is an imaging-based study. It's safe and effective. It should hopefully get incorporated into screening and have a major impact on colorectal cancer rates in the future. It allows for research not possible by colonoscopy, that sort of longitudinal look. For PET-MR, it's a new modality that really has the potential to help in staging and treatment. Thank you.
I was wondering, because I sit on the National Colorectal Roundtable Steering Committee, and I think Perry Pickard is actually receiving an award from the Roundtable because university, you guys are one of the only hospitals and hospital systems that actually have truly achieved 80% already. So how did you do it? What's the special sauce? Do you think this is part of the CT colonography is part of that?
I think it's part of it. We only account for 10% of the overall screening efforts right now, but I think what really drove it, it was a sort of everyone working together approach. So there was something called CCPI, which was this initiative to, because our screening rates were like dismal. They were like 60% or something. And we had this initiative led by Sally Kraft. It had gastroenterologists, it had radiologists, it had patient advocacy, it had hospital people, and said, how do we make the system work to improve screening? So part of it was, with our electronic medical record, EPIC, there were ways electronically to get immediate flags on that said you need screening, so that the primary care was notified when the person was out of screening, and we monitored rates, we tried to improve access, and it was like multiple meetings and stuff like that. But it was the work of many different people all working together for the same cause. And
Yeah. So I've been waiting to ask you because I was very excited about this. So, so we are wildly behind schedule, not because of you, because we were running late actually. So apologies, because this has been awesome. Do we have one or two questions, and then Dr. Vassetti is going to present because he's got some awesome info. Any one or two questions for Dr. Gibb?
Just really quick, did I miss? Is there any difference in the prep for CT scan?
It's pretty much the same prep. We do, you have to get your colon completely cleaned out. But we do, and then we give you some stuff that, there's always a little bit left behind, and that gets tagged. So it's pretty much the same.
Pretty much the same, okay.
And so Sharon and I were at the AACR conference, and we were literally blocking both entrances trying to talk to Dr. Kim, but he's such a rock star that literally we had to have to wait our turn to talk to him today when we were here. So it's an honor to have you, and this is awesome. So thank you so much. So everybody, I know we're getting refreshing and all. What I was hoping we could do is Dr. Bassetti would give his presentation. When we are getting ready to do the tour, we would hit the bathrooms on the way there. So we're probably going to do a break tour kind of combo. Is everybody okay right now? Are we good? All right, we'll take one or two. So one of the things that I learned about Dr. Bassetti last night, not only is he an amazing radiologist, oncologist, and immunologist, but he also did his some training in Denver. But I was wondering, since you left Denver, that 13 millisievers is now 10 based on your radiology. So I was just thinking about all of us Denver kids. But so it's an honor to have Dr. Bassetti, and I think even last night I learned some awesome different approaches to therapy, and the work that you're doing is amazing. So take it away.
Great. Well, thank you so much for having me. It's a pleasure. This is a different forum than I'm usually talking at. Usually we're talking to other of our colleagues or people interested in cancer therapy and that have medical background. So if I use terms here at all that are not understandable, please interrupt me and ask what's going on. I'm very, this is a unique forum where it's very small, and I love the interaction and asking questions. So don't feel any shyness of interrupting. We were at the wedding together last night, so you should feel very So I am in the radiation oncology department here, and so I treat essentially cancer with x-rays. So there are higher energy x-rays that are used with CT scans, but essentially aiming x-rays at where we see cancer or where microscopic cancer is suspected to be is the culmination of what I do. And I'm going to tell you a little bit about the role of radiation in both rectal cancer and colon cancer, and some of the technology that's present at the University of Wisconsin, which I think is very, very unique. People were asking what's the difference between an MRI and a CT scan. One of the unique things we have here is radiation that's delivered while watching by MRI, and there's only 5 places in the world that have that same technology. So as you probably have realized through your own experience with cancer treatment, it is a combination of different therapies that gets involved. So we have medical oncology that delivers chemotherapy, surgical oncology that does surgery, and radiation oncology that does radiation. And there's more beyond this. There's radiologic interventions with ablation procedures. But these are probably the 3 most commonly recognized. And often the best outcomes are driven by a combination of these different therapies. I think they each have their role in different situations. So radiation therapy is essentially, like I said, very high energy x-rays aimed at the cancer, and it works by causing damage in the DNA of the cancer cells. And the DNA repair mechanisms of cancer are not as well intact as your normal tissues, and so we can cause more damage to the cancer cells than to the normal tissue. And that's the crux of how radiation works. There is a lot more going on than just that. There's the interplay with the immune system and other processes in the body, but that's the general explanation. So specifically in colorectal cancer care, I'm going to split this up into talking a little bit about rectal cancer, where radiation plays a much more prominent role, but also talk about colorectal cancer, in particular metastatic colorectal cancer. There have been trials looking at its use in non-metastatic colorectal cancer to a limited extent, and it's not as highly used there, but there certainly are some situations. I'm not going to talk about that today, but we'll focus really on rectal cancer and then metastatic situations for colorectal cancer. So first, rectal cancer. So what are the benefits of having radiation before surgery? I heard last night a number of you guys mentioned that either you or family members were stage 3 rectal cancer and probably have received some radiation prior to your surgery, sometimes after surgery, and sometimes not at all. The main benefit of radiation before surgery for rectal cancer is really decreasing the chance that this cancer comes back in the same place where it was removed from. So a local recurrence in the tissues right around the rectum or in the lymph nodes right nearby there. One of the other potential advantages is in what I call organ preservation, essentially avoiding the need for a permanent colostomy. So there's some evidence that patients who were felt to need a permanent colostomy after they had undergone their chemo radiation were able to have a anal sparing procedure done. And I'll talk to you a little bit about the surgeries that are done in this, because I think understanding how we deliver radiation is hard unless you have the context of what the surgeries are. And then the other advantage of doing the radiation before surgery is there is less toxicity from the radiation that's done before surgery rather than after surgery typically. So most patients with a rectal cancer will be seen by a surgeon, and they'll talk to you about the type of surgery they're able to do. This is a diagram showing surgery that's able to preserve the anal sphincter. So this is your colon, and you come out the sigmoid colon down here, and this is where a representative of a tumor is, with some normal colon beyond that. And then this is where the anus is, and this is where the muscles that hold your stool back from, so that you don't leak stool all the time, go. And those muscles relax when you need to have a bowel movement, and they shut off when you don't. And so a surgeon will look at the position of the tumor and see if can they cut beyond the tumor and before the tumor, and then essentially sew this back to here and reattach things. Often people have a temporary colostomy in between that period of time, but ultimately this is how the surgery will result, if they can resect this without needing to take the anus out. So if we looked at that anatomically, now I'm taking a slice right through the middle of the patient. So the front of the patient's over here, the back of the patient is over here. So this is your tailbone, this is the anus, and the rectum is this tube space right here. Bladder's in front of here. And you can see in this diagram there's a tumor arising in the back wall of the rectum. So there's the rectal wall, it's invading through the rectal wall, and a diagram of tumor deposits or lymph nodes in the soft tissues right around the rectum. So what does the surgeon do when they do this? So I'm just kind of highlighting where the surgeon will cut. So they'll do something called a total mesorectal excision. They'll try and take out this entire space around the rectum with the tumor and all in one big procedure. So they're cutting where that red line goes. But you can see there's cancer potentially very, very close to here. And what radiation before surgery is really doing is probably taking care of those microscopic cancer cells. We do treat the tumor as well, and we can assess how well the cancer cells responded in the main tumor. And that's probably how reflective of how any microscopic cells elsewhere responded as well. And so we get an idea of that after the surgery. And Dr. Kim showed you some efforts to try and look even before patients go to surgery after radiation to see, are there people who don't actually need surgery? That's one of the questions. And there probably is a subgroup of patients that would have a complete response to their cancer. We see that in about 15 to 20% of patients where we don't see any residual cancer at the time of surgery. And the question is, do we get every last cell, or do the pathologists not see that one residual cancer cell? So at this point in time, we pretty much take everybody to surgery. In the Netherlands and in Brazil, there's a large screening programs to avoid that in some patients, and that's being looked at in clinical trials currently. So for this type of treatment, what I'm looking at usually is an MRI. This is one of the MRIs that Dr. Kim did, and this is showing that rectal tumor here. So you can see right in the middle here, a rectal tumor. I've highlighted it right around there in blue, and that's arising again off the posterior wall of the rectum, kind of similar to the diagram. There's a little bit coming in from the side that you see. And you can see that there's a good amount of space where we don't see tumor down before you get to the anal region here. So in this situation, the surgeon likewise would after radiation, plan a resection in this area and then attach things back together. So what about if the tumor is in a much lower position? So here that shows the tumor really right up against the distal rectum, right where the anus is. And in this situation, the surgeon doesn't have any room to get beyond that and would have to cut into those muscles, the sphincter muscles. And this is what makes patients need to get a permanent colostomy. They think they can't resect this and put things back together without leaving you without that muscle function, then there's no point. You would just leak stool, and so having a permanent diversion colostomy is necessary. We still do the radiation because the recurrence risk is cut by about half if we do radiation in that situation. So this is the patient before. Again, the surgery would go in this area. This is a patient with a much lower lying tumor. You can see the tumor in this situation is outlined here in blue. It's much lower down in the rectum. This also has a lymph node back in the posterior. This patient's at much higher risk of recurrence because we know that there's been spread in that area. But right near here is the anal sphincter muscles. And so avoiding surgery through that area is really tough while still maintaining a margin around that tumor. So in this situation, the surgeon really probably is going to need to cut all the way around here and need a permanent colostomy.
I've never understood the difference between a colostomy and
An ostomy?
yes,
There's ostomy. I think just means the
placement.
the placement. Yeah, and then there's depending on the portion of bowel that's moved there, you have different types of ostomy. So you have if it's from the colon, you have a colostomy. If you have a ileostomy, it's from the ileum portion of the bowel.
Same thing, just the placement that changes the name.
It's the portion of bowel that's diverted to the surface that changes what types of. So, and there's variations on that. There's probably a lot more beyond that, but that's kind of the general gist of it. So again, the benefits of radiation before surgery is really decreasing the chance of a local recurrence. And again, that does that by about half. And then potentially organ preservation, so converting that patient who had that really low-lying cancer. It's possible if we can shrink this tumor enough and sterilize any microscopic disease right there, that at the time the surgeon goes in 6 to 8 weeks after the radiation, it will have shrunk enough that they will be able to do a organ sparing or a temporary colostomy and then reattach the plumbing, if you will, at a later time point. And so that's one of the things that patients really, when we talk about that in consultation, that's the thing that patients really almost always focus on. Yeah.
So I am a rectal survivor that had nightmare radiation, but this is 10 years ago. Like, there was a horde. So anyways, but my question is, I don't recall being told, and so you keep saying that radiation really decreases the reoccurrence of cancer, and I'm not even sure if I've ever heard that concept before, because now I'm wondering if that's true, then what about if they, want to do post-operative oxy? I guess those two go together, or what? Have you ever done studies?
Post-operative chemotherapy with oxaliplatin?
Yeah, but yeah.
Yeah, so most patients who are high enough risk to need chemo, we usually do chemoradiation, so they'll give you a 5-FU or sometimes an oral version of that called capecitabine at the same time as the radiation, and that tends to work more effectively than radiation alone. Then after the surgery, often patients, once you recover from surgery, will end up getting usually about 6 months of chemotherapy, typically 5-FU and oxaliplatin based, or some variations on that. So the feeling is they're kind of doing separate things. Radiation is really affecting the local recurrence chance, whereas the chemotherapy is affecting any distant spread or microscopic cells that would have been outside of that radiation field. So if that one lymph node I showed you wasn't the only lymph node, if there's a lymph node further up that's outside of the radiation field, possibly chemotherapy will decrease the risk of spread distantly.
Okay, so let me see if I understand that correctly. So the local reoccurrence is more of a rectal reoccurrence versus the chemotherapy post-surgical is more of a spreading reoccurrence?
Yeah, so chemotherapy is going to go everywhere and help decrease the risk of recurrence.
Somewhere else in the body.
Somewhere else in the body. And it will also affect locally to some extent. But the advantage of chemotherapy and the disadvantage is really that it goes all throughout the body. And so microscopic cells that we can't see can be treated by chemotherapy. That advantage is also its downside. It goes everywhere, and so it has a lot of sort of different possible side effects because it affects a lot of different organ systems.
Right. Well, I opted not to do the post-surgical oxy, but I definitely did the radiation and 5-FU. But I don't know if I've ever heard that combination, or maybe I have. Or, sometimes when you hear things over and over and over again, it finally sinks in. But that just seemed very profound to me, what you said about the local reoccurrence and radiation, and then the chemo does outside of the primary.
We tend to think of surgery and radiation as local therapies and chemo as sort of systemic therapies or distant therapies. And so you'll hear me talk about local recurrence a lot. Yeah, because radiation really, in rare circumstances, someone go to an organ or a bone marrow transplant, we might do whole body radiation. But the doses that you can treat are much, much lower, and it's something we tend to avoid. Radiation is really effective and usually reasonably well tolerated when it's very localized. So for some patients who have very low-lying tumors, it can be really uncomfortable, this type of procedure.
Oh, yeah, I was in a
which
wheelchair.
which I'm assuming.
I was in a
when you said
wheelchair
that.
for the last 2 weeks because my bladder was on fire and I couldn't have a reversal
Oh, wow.
and now I have to have surgery every 3 months to put stents in my ureters because of the radiation damage.
Wow. Yeah,
I'm
that's a very
a poster child for what went wrong.
that's a very atypical. This is among our best treated treatments. So
I know, I'm not normal.
I'm sorry. That
In many
sounds
ways.
terrible. Okay, so yeah, and then doing the radiation before surgery, often much of that radiated tissue is then removed. So some of the risk of late secondary malignancies 30 years in the future maybe reduced by that. But it's probably more so than anything, it's the if we do radiation after surgery, all your normal bowel has now fallen in that position. There's scar tissue after surgery, so it's not moving in and out of the field. It's just stuck in place. And the radiation causes more scar tissue and can cause more side effects at that point. So we tend to like to do it in advance for several reasons. Partly the chance of avoiding a permanent colostomy, but also partly because the toxicity is less. So modern radiation has changed a little bit. So there's a lot more imaging involved that helps us target the radiation better. There's also the ability to shape the radiation much better than it used to be. And this is the thing that really drove me into the field, was being able to put a focused dose of radiation in one spot, or create combinations of radiation fields that curve around organs that you don't want to treat, but target the organ that you do want to treat. This helps in a lot of situations. There's still a lot of situations where we use sort of older fashioned techniques because we don't think we need to use sort of more fancy techniques because of billing issues and other reasons sometimes push us in that direction. So, and then the other, so we can shape the beam, and I'll show you some examples of how that's done. And then we'll also talk about just the improvement in quality of imaging before and after treatment. And now treatment with, under the guidance of magnetic resonance imaging, MRI, allows us to watch as the patient's responding and potential for changing treatment midway through therapy. Right now, what we deliver is pretty standard. You probably got the same dose as radiation as I give most of my patients. Probably 25 treatments and then another 3 treatments or 20 treatments. Those are very standard dose of radiation for refractory cancer patients. But we know that different patients respond differently. And there may be some patients who are resistant to the radiation that we want to alter what we're doing. Or there may be patients that are very sensitive. We can either back off on the radiation, or we can escalate those patients and see if they can get rid of all their cancer without needing the surgery. So there's a lot of potential here. And I think understanding how individual patients are responding during treatment allows the possibility of tailoring their treatment. But let's talk about shaping the beam of radiation. So this is just an example of a linear accelerator. The radiation's generated, they speed up electrons to very, very fast speeds, come in here, they loop around a little magnet, come down here, slam into a piece of metal, and that creates X-rays. And those high energy X-rays come out usually in the shape where you just have a square. But then there's a little area down here called collimators, multi-leaf collimators, which are all these little sliding leaves here. So this is the radiation coming from deep in the screen out towards us. And these leaves can sort of slide back and forth on one another and create a complex shape for radiation. And that can happen in dynamic changes. So those can move during the treatment, and these complex shapes come together to create very complex shapes. And I'll sort of give you a little example of how this is a little promo video, so it's a little bit marketing set. But this is just, I think it'll give you a sense of how these move. So these little leaves can move together on one another. And then only where there's a gap does it allow radiation through. So I'm just going to pause this for a second. The radiation is coming down, and that's the light from the top here. They're leaving a little tiny gap open here, and you can get very, very small areas of radiation. So we can put very pinpoint radiation in situations we want to. So, all right, I'm just going to continue this now. And they'll be able to move this wherever they want. Those leaves, you can see them up sliding back and forth. We can do much more complex shapes than just a small area. So they can let various different shapes of radiation come through. And we usually have a plan that we'll look at that's the culmination of all those shapes. And we use computer systems to create the shapes that we want so that we can sculpt the radiation around areas we don't want to hit.
So you can, if there's a tumor of an odd size, you can basically change the shape of the radiation to target whatever funny shape that actual tumor is to shrink it.
Yeah, and that's actually one of the big advantages of this. If there's round things, we can target very easily with just sort of fixed shapes. But shapes that are sort of crescent shaped or sort of loop in are very difficult with conventional radiation to
Now, a
target.
friend of mine had whole brain radiation, and she had to get this mask.
Yeah.
What is the purpose of the mask?
The mask really holds you steady, so you don't suddenly, so whole brain radiation is very standard, older school radiation typically. There's variations on that now. But usually radiation comes from one side and then comes from the other side. We don't want a patient to suddenly turn their head or move position
And
during
it shoots goes somewhere.
go somewhere we're not intending.
Yeah.
Yeah. So a lot of radiation is either watching to make certain people are in the, and the tumor is in exactly the right position, or doing things externally to hold them in place. Most of what radiation oncology is, up until the MRI guidance, is looking before treatment. Then when the radiation's on, we're not able to look. MRI has changed that, and I'll give you some examples of that. So this is a rectal cancer radiation field. And it's a little difficult to look at. This is a CAT scan example, but I just wanted to show you kind of, here's the rectum, here's that fatty space around here. So here's where the microscopic disease is going to be potentially located at. You can see the patient's hips are here. Whoops. Traditional radiation would have sort of come and treated a big square that would treat most of that hip. But you can see how the high dose radiation stays off of those hips. Even the moderate dose radiation is now being sculpted around there. There's a little effort here anteriorly to stay off the bladder. You can see the high dose radiation stays off that. This is, again, a slice down the middle of the patient. Again, here's the bladder, so you can see that there's effort to stay in off of the bladder here. This radiation field goes up higher than standard because this patient had some nodal disease and was concerned about spread in the lymph nodes, so wanted to track the lymph nodes up a little bit higher. In order to track up here, in order to avoid high dose out here, there's a little dose that comes out here, but you can see this is bowel that's being avoided. We're only seeing this now in one dimension. That bowel is being avoided sort of in 3 dimensions. From the high dose, there's still a little bit of spread of the rectum.
So what is the result in the body then in those lower dosage?
Usually it's much better tolerated. So you know, what we're really trying to avoid here is long-term issues, long-term problems of needing stenting, needing sort of chronic needing to manage chronic side effects from the radiation.
So it just kind of destroys the tissue? I mean, it's not focused on the cancer,
Right,
cancer
so-
cells itself, it's all the cells.
So yeah, so the normal body, the reason we give radiation in this type of situation over the course of 5.5 weeks is by giving a little dose each day. We give enough dose that instead of lethal damage to cells, it's called sublethal damage. So it's got the potential to kill the cell if the cell doesn't repair that damage. Your normal cells aren't dividing fast. Anytime they have damage, they look around and they say, oh, there's damage, let's repair that. And if we give them a day to recover, the normal tissues recover from that damage, but the cancer doesn't so much. And so that's why radiation is given over the course of 5.5 weeks instead of all in one day. Yeah, that's a really good point. But I think one of the things that's underappreciated is sort of chronic long-term side effects from radiation. And this technology gives us the ability to do that. It's not as, rectal cancer is a situation where, we want to treat a large area. This whole area around the rectum is at risk. And so we're not, it's not helping us as much here as it is in some other situations, but it certainly, I think, can help. So again, radiation before rectal cancer really decreases the chance of recurrence in most series by about half, local recurrence. And then the ability to avoid a permanent colostomy seems to be about 1 out of every 5 patients who's thought to need a permanent colostomy may have a chance of avoiding that. That comes from a big trial called the German rectal trial. And then again, less toxicity done by surgery.
I'm sorry, what did you say about the German rectal trial?
That's one of the big trials that we look at to decide that really shifted us into doing radiation before surgery. So that was a trial that compared radiation with chemotherapy before surgery to radiation with chemotherapy after surgery.
What year was that, do you know?
Mid-2000s.
So you could just Google that, it probably would come
Yeah,
up?
if you type in German rectal trial, it'll probably come up. The first author's name is Sauer, S-A-U-E-R. I can certainly disseminate that if you're interested.
I'm interested.
And that was a trial where they made the surgeons say up front what type of surgery they were going to do. And so that's when they really figured out that, hey, 1 out of every 5 patients that the third surgeon said that they were going to need to do a permanent colostomy on, they were able to do temporary colostomy and reattach the plumbing. So that's kind of driving a lot of this data.
Interesting.
Okay, I was just going to switch gears a little bit. This is a patient that had a colorectal cancer that metastasized to the brain. This isn't something you see very commonly. Colorectal cancer doesn't usually go to the brain. Well, there's a lot of colorectal cancer out there, and sometimes it does. And you were talking about your friend who had whole brain radiation. If we saw this happen 10 years ago, we would have treated the patient's whole brain after they had surgery.
Well, why wouldn't you call this a second primary cancer?
So the patient presented with neurologic symptoms, and so immediately they took them to surgery because the quickest way to reverse those and avoid them becoming permanent is to take the pressure off the brain. You can see in this patient, the cancer is very easy to see. That contrast that we give highlights the cancer.
The red arrow helps.
Yeah. So this is something I learned from my radiology colleagues. It's the arrow sign. It tells you very well. So all this white is swelling from this tumor around here, compressing the brain tissue there, and that's causing the neurologic symptoms. So the fastest way to deal with this is for the neurosurgeons to remove that tumor, and it's very close to the top of the brain, so they're able to sort of make a cut, remove some of the bone, and go out and remove that tissue. They know it's colorectal cancer because then they look at it under the microscope there, and the patient had colorectal cancer. It was exactly the same type under the microscope. So it's colorectal cancer that's spread to the brain as opposed to being
Skip the other organs and went to the brain.
Yep.
So it's when you look under the microscope, if the tumors present the same?
They can sometimes they can't tell, but in certain situations, there's various tests that they can do that tell them, hey, this really is from a colon primary. There's various stainings, we call them, that they do.
Like, it might be good for you just to take a quick step back and talk about like a second primary and then a metastases, just quickly
Yeah,
about that.
so most people who have cancer just have one type of cancer. There are patients who have genetic syndromes that make them at risk for having 2 different cancers that arose independently of one another in different organs. So, for example, breast cancer patients with certain mutations also have a risk of ovarian cancer. The various syndromes that put you at risk for colon cancer also will have a risk for other types of cancers. So we do come across it sometimes where somebody has a different type of cancer. So they might be a heavy smoker and have a lung cancer in addition to a colon cancer. I've had that where a patient is being treated for lung cancer, we get a PET scan, all of a sudden there's something that lights up in the colon. Lo and behold, they're diagnosed with a colon cancer unsuspectingly. And so in this case, one of the questions was, colon cancer doesn't usually go to the brain. It's not common like it is in lung cancer or other cancers. What is this cancer? And so the pathologists look very closely at this once it's removed to make certain we're not missing some other cancer that we need to deal with at the same time. Whereas a metastasis is actually spread of the primary cancer to another organ. So colon cancer likes to spread to lymph nodes, but then to liver, to lungs are the most common places that it typically spreads. But I just wanted for this group to make you aware it can spread other places. It's not that it only spreads to those places.
But I thought it would be just 2 different primary cancers. But
Yeah, and that's when I saw this, I can't remember if I knew that this patient had colon cancer before I saw this, but that would be my first thought, that this might be from a different cancer. But we can tell because it was surgically resected. We can't tell from imaging. But you see all that swelling around here, and so the surgeons take this out and are able to decrease that swelling. Well, typically after surgery we would have treated this patient with whole brain radiation, but there's some long-term complications of whole brain radiation, including this memory loss, effects on how quickly and well you think. And so we, more modernly, we like to avoid that and do a much more focused treatment with radiation. So this is now the tumor has been removed, the surgical cavity is only left behind. The surgeons in the brain, unlike in the colon, they can't take an extra 2 centimeters around this and remove all that extra brain tissue and say, fine, we're done with this. They take out everything they can see in the operating room, but there's always microscopic cells left behind, and so we would always irradiate afterwards to reduce that risk. So this patient, and then follow it with surveillance with MRIs to make certain other lesions in the brain didn't arise. Now, some patients that have brain metastasis have 10, 20 metastases, and in that situation, we were doing whole brain radiation. That's absolutely the right thing to do. A big quality of life trial came out from brain metastasis maybe 5-10 years ago, that when we were doing the whole brain radiation after surgical resection, that again showed what we already knew, that we decreased substantially the risk of local recurrence with radiation by treating the whole brain, but we weren't improving patients' quality of life. And that really changed the thinking about treating with whole brain radiation for situations where there's limited number of metastases. So now it's much more common to get either stereotactic radiosurgery if it can't be removed surgically, or this is what we call fractionated radiosurgery. It's just essentially 5 treatments of moderate to the high dose radiation to just that local area. It tends to be much better tolerated than whole brain radiation. But we do need to follow this patient with MRIs to make certain there's not other lesions that arise. And that's a critical part of this. But this is also that shaping of radiation that really makes this possible to do. But where colon cancer or rectal cancer more commonly spread to is the liver. And I'm sure that some of you guys have had cancer spread to your livers. And it used to be a long time ago that we said that this was incurable, that there was no long-term survivors once cancer had metastasized. And from data that was done largely with surgery, but also with other focal treatments like radiation or ablation type procedures, we now know that there is a subset of patients who can do extremely well if you give aggressive local therapy. So when somebody spreads the liver, one of the first things we're thinking about is this somebody who ultimately is going to be able to get surgical resection of this? That's usually our first line therapy. The liver is very unique in that you can remove a large portion of it if it's a healthy liver, and it'll grow back within 6 weeks, all that function. So if a patient can't get surgical resection, and this patient couldn't get surgical resection, this is, again, an MRI showing the liver. So this is a slice sort of right through the middle of the patient, and these are sort of other orientations. So this is front to back, and then this last one down here is a slice like this. So we can look at it in all different orientations. And this is a diagnostic MRI that probably Dave or one of his colleagues did, where they give a contrast agent that's really well taken up in the liver, called Getoxicate, or Eovis is the trade name you might hear. But the liver takes that contrast agent up, but the tumor doesn't. So you can see this dark area right here is actually a metastasis from a colon cancer. If we look on this direction, we can actually see that there's a subtle, smaller other metastasis right here. And so this is a patient whose tumor was too close to the vasculature here to be able to get around it surgically and safely. And so they ended up undergoing very focused radiation just to the tumor. And in 5 treatments in what we consider an ablative dose. So now instead of trying to avoid the normal tissues around this, in liver or lung, what we do is we sacrifice a small rim of normal tissue right around this tumor and give very high doses of radiation just to that area. So there's no recovery of the normal cells or the tumor cells in that area. And this has control rates for colorectal metastasis on the order of about 70%. So if we're talking about primary liver tumors, it's up 95%. But colorectal cancer metastasis control rate with radiation is about 70-something%. And there's possible reasons why it's not better than that. But that's one of the reasons why we typically go to surgical resection first.
You're able to focus enough that you don't hit that artery.
The artery will receive some dose radiation, but arteries are really tough. They have a lot of connective tissue and other things that don't contain DNA. Damage to that is not going to be damaged by the radiation. It's really only the cellular structures that have DNA. And so arteries are surprisingly resistant to radiation. This patient underwent treatment with MRI-guided radiation, and one of the big problems with liver is if you remove too much liver, you're in trouble. Similarly, if you irradiate too much liver, you're in trouble. This lesion was sort of right in the middle of the liver, which makes it tougher to us. If this was sitting way down here at the tip, we'd be able to really avoid all this liver up here. But right in the middle of the liver, it's tougher, so we don't want to miss. And then what makes that even tougher is that as the patient's in the treatment unit breathing, their diaphragm is moving up and down, and that's pushing their liver up and down. So the tumor is not sitting still, it's going like this. So if we don't want to miss, we need to either encompass the whole movement of this or do something about that motion.
And breathing is good.
We do want the patients to breathe. So one of the unique things about Wisconsin that I wanted to highlight was that we have a tool for MRI-guided radiation. And that's this machine. Hopefully we'll get to see that when we do the tour of our department. And this is, like I said earlier, there's only, I think, 5 of these in the world. We were the second to have this. And the way that this works is it's actually got 3 radiation sources. So this is a radiation source, this is a radiation source, and this is one that's not turned on. And they converge sort of on the center here. These are those collimator things that I was showing you that help shape the beam. So it's got 3 sets of those that can adjust the shape of the beam.
So shape it in 3 dimensions.
Yeah, so any one of these, and then this whole axis can rotate around the patient. So the patient lies longitudinally right through the middle of this, and this can rotate. So if you look at the MRI, this is a very unique MRI in that it's got a split bore. So this is, the patient lies through the middle here. This is MRI, this is a magnet portion of the MRI, this is a magnet portion of the MRI. In the middle, it's got this rotating ring. Technologically, this is really tough to do, to split up your magnet like that. Really makes it tough to keep good quality radiation or magnetic fields to get good imaging. And so this is a little lower field strength magnet to make that possible. So it's not as high of a strength magnet as the diagnostic MRIs that Dr. Kim does, but it's good enough to see a lot better than we currently see. And it's got no radiation, so we can watch continuously while the treatment's going on.
I have a question.
Yeah.
So, has there been any studies to maybe quantify how the side effects, how less of side effects there are? That's not the way to say it, but I mean, like I had mine 10 years ago, which I know I didn't have this technology. So, you know, the reduction of side effects from this technology versus.
So not from the MRI, because the MRI is brand new, and we've had it for a couple of years, but you know, there just haven't been enough patients treated with that. Those MLCs, the shaping of the beam, that's around and that's available on other units. And that has not, I don't think in rectal cancer there's been studies. Head and neck cancer, where there's a lot of important organs right next to areas you're treating, they did seminal studies showing that the long-term outcomes from patients undergoing head and neck cancer with intensity modulated radiation, which means we move those leads around and use computer algorithms to avoid the organs we don't want to hit. That really changed the lifelong function for those patients. And so while it hasn't been studied as much in rectal cancer, there are situations where I use it in rectal cancer and situations where I don't. Where usually it's, so for the liver treatment, I would definitely use it there. Getting a very focused dose is critical. For most rectal cancer patients with upfront therapy, I don't use it. Part of that is because insurance doesn't pay for it in a lot of situations. And so if I think it makes a difference, then I do use it. If I think it makes a small difference, then I'm in a controversy. It always makes a small difference, and it's just a question of how much is that worst cost benefit to the system, and can I get it through insurance, and does it delay the patient getting started on treatment? So there's this whole another level of it beyond just, you know, can I do a better job? I think almost always I can do a better job, but it involves a lot more effort and cost. It's not just me, my time and effort, which it certainly involves a lot more time and effort to do this type of planning, but there's a whole host of physicists behind the scene and dosimetrists who are involved in that planning situation. So it does definitely add to the cost. And so we try and use it somewhat judiciously. So I just wanted to give you an example. For that patient who was going to go liver treatment, if we just look with our best quality imaging on a conventional state-of-the-art radiation unit now. So this is what's called a cone beam CT. So when a patient lays down for their treatment, they'll either get, there almost always is some imaging that happens to make certain we have them in the same position. Some of you probably got small tattoos placed on you, and that's a very, we do that still as a starting place, but that's conventionally, that's how things were done before we looked with imaging. So usually if somebody's coming for a month and a half, we'll put those tattoos on them, use that as a starting place, and then at least once a week do some sort of imaging. So often that's just an x-ray or a plain film to make certain that they're roughly in the right position based on their bony anatomy. There's another way where we can use the actual radiation machine to take some images called a cone beam CT, and that's what this is. This looks good in other situations where there's not movement, but in the abdomen, where the liver is at, it's terrible. I mean, I can't tell what's going on in the middle here at all. I can see the bones really well. So if I just account for that movement by putting a movement of the tumor by encompassing the whole area that the tumor might move, well, then I can set up to the bony anatomy, and I know that I'm roughly right, and I add a margin for error. But what I'd like to do is I'd like to just watch the tumor and only treat it when it moves into the right position, treat it this amount of tissue, let it go out, turn the radiation off, have it come back in, turn the radiation back on. That would be the ideal. There's some ways to do that without MRI guidance, but I think MRI guidance is very helpful. So in that situation, I need to set up to the internal organs or to the tumor in the liver. You can just see how much better you can see the anatomy in here. I can see the kidneys stand out. The liver, I can see really well. The gallbladder. Here's cut right through the duodenum, a portion of bowel. Here's the other side of that. Here's a lymph node that's involved with cancer. I can't see that on any of this on a cone beam CT. It's not the same patient, but it's an example of what it looks like. One of the very unique things about radiation under MRI guidance is that we can see the actual tumor. So sometimes this procedure is done without watching, but by placing small, what we call fiducial markers or gold markers into a tumor, so that then we can take x-rays before and after or cone beam CT and actually see those. But this lets us see exactly the tumor. So I'm highlighting the tumor here. Here's the lung above. This is the liver. This is the tumor. That green is tracking the tumor, and the red is where the radiation is going to go. So I'm just going to turn that off. You see the patient here is actually holding their breath. So we're able to see that the tumor is in the right position. They can hold it there for a long time, and the radiation is ongoing. These are actually the three sources down here. So that one's treating. These two are ready. You'll see that they go to orange when they're on. And then when the patient needs to take a breath, they take a breath, the radiation is automatically turned off, they go back to yellow or green. And then the patient takes another breath. Sometimes the patient takes too deep of a breath. This would miss, so the radiation doesn't automatically turn on. We're able to tell them over earphones, hey, let out a little bit of air. They're able to let out a little bit more air, move the tumor back into position. We can watch and confirm that it's in exactly the right position and go ahead and treat. This lets us avoid a lot more area that otherwise might be treated. So instead of treating this whole area where the tumor travels and normal liver, we can treat just the tumor. This is a bigger deal if the tumor is right at the end. So this is actually bowel right down here. If the tumor was right here and I tried to do this, bowel would move up into the area and I wouldn't be able to give an ablative dose of radiation. So I think this really helps us a lot when there's motion and when we're near critical structures. So not only the soft tissue resolution and being able to set up with alignment very well, but motion tracking and being able to adjust and treatment and turn it on and off when we want to. Radiation is not often used for colon cancer. There are situations where there's a high risk of local recurrence for colon cancer. So if somebody presents with a perforation, they've got a very high risk of a local recurrence, even with surgery and systemic chemotherapy. T4 tumors, T3 tumors with nodal disease also have a high risk. There's been one randomized study looking at radiation it's probably started 15 years ago or something, that didn't show a benefit to radiation for colon cancer patients. It's hard to know whether that's gotten radiation out of most of colon cancer patient treatment. That study only accrued a quarter of the patients that they intended to and didn't show a difference. So it's hard to know if there's not a statistical benefit because they didn't accrue enough patients. But radiation was clearly a little bit more toxic in that situation. One of the ways we might be able to do a better job in the abdomen if we ever do radiation in that situation, is by seeing what we're doing. Sometimes the colon can move substantially, and understanding exactly where we want to be treating may help with that situation. So right now we don't use it much in colon cancer unless it's metastatic, but it's possible that in the future this might help decrease the toxicity and increase the benefit of that type of treatment.
So I've seen a number of posters recently and more in the literature talking about radiation and palliative care, and this sort of approach. So I know we've talked about it from like a treatment curative standpoint. When you see that, because we have a number of folks who have done a lot with ASCO palliative care work groups and advisory committees, when you see radiation and palliative care, what does that mean in this context? How would you frame that?
Yeah, so there's a few things. So a lot of patients that we treat are for palliative reasons. So often patients have pain because the cancer spread to a bone, or they've got a lymph node that's pushing on something. Obstructing a ureter is a common one. Probably the most common for colon or rectal cancer is that they've got a tumor that's growing while they're on chemotherapy, and now they're looking at potentially obstructing, and they either need a diversion. Often we'll do radiation concurrent with chemotherapy. Often gives us a little bit of benefit. So that oral chemotherapy that sometimes we do with definitive rectal cancer patients, we will do in a palliative setting to try and shrink the tumor so that it doesn't cause those obstructive symptoms. Dusty and I have a number of patients that have undergone palliative radiation. And in some situations it's helpful, and in other situations it's not. And usually we get together as a group and say, what's going to be the most useful? If we give them 10 to 15 treatments of radiation, well, they got to come 10 to 15 times, and for some patients that's tough. And in other situations they're local and that's doable. And then how long are we keeping them away from other systemic therapies? That's another big thing. So usually the big driver is if they have symptoms, and if it's something that we can clearly see the cause of the symptoms is one area that can be treated with radiation. There's a lot of palliative treatments with radiation. So I think it has a big role in palliation, and it's one of the more satisfying things, quite honestly, that we do, because oftentimes we can make a big impact on just how patients' quality of life is because of that. Okay, so I think there's a lot of advantages that the MRI guides, the soft tissue resolution, and the motion management I talked to you about. One thing I'll talk about in a second is just assessing response within treatment. So we have all these images every day. So every day the patient gets set up with a high quality MRI image. So if something has changed, we can see that. Instead of sort of doing it once every 5 treatments with an x-ray, we get to see if something really has changed. But right now I don't think we're making changes based on that. We're not changing treatment based on how somebody's responding during treatment, but I think there's a lot of potential in the future to do that. So this is just an example of a patient. You can see they're not quite as crisp of images, but I think crisp enough that we can see a lot better than that cone beam CT, for example. So this is a pre-treatment images in 3 different planes. This is the somebody mid-treatment. So just look at this image. You can see the tumor sort of, here's the rectum. You're seeing it sort of in longitude right here. And then here's the tumor. This patient has a relatively small tumor comparatively, but you can see it starting to shrink a little bit. And this is mid-treatment. Most of the patient's tumors, most of the response actually happens in the month or so after treatment's over from radiation, which is why the surgeons wait a month or 2 months, and there's continued response. But one of the things that potentially in the future we'll look at doing is seeing are there patients who are really responding well during treatment who we potentially could avoid other therapies. So for somebody who needs a permanent colostomy, we know that there's a subset of those patients who respond so well to chemo and radiation that their cancer is not going to recur even if they don't have surgery. We just can't pick those patients out from the group. It's a subset, so the majority of patients will need surgery, but how to tease out who those patients are is very difficult. But I think this is one of the things that will only get better and better, and we'll be able to tailor therapy to an individual. I want to just switch gears right now and talk about something that I'm very excited about. As was mentioned, I have a background in immunology, so I trained as an immunologist, and I have a lot of enthusiasm for the immunotherapies that have come into the clinic. This has been a fantastic realization for many patients with metastatic cancers, particularly of other types. But this is one of the ways that these immunotherapies work is something called an immune checkpoint inhibitor. your body has these aggressive cells called T cells right here. These are the cells that patients with HIV or AIDS lose, and that's why they are immunosuppressed. These cells go around and they look for foreign cells or cells that aren't right. And this is an example of a tumor cell, the surface. That T cell comes and it looks at little particles. This yellow particle is a sample of that the tumor cell presents. All cells of your body present these portions of themselves on the surface in the context of this molecule. And they say, okay, is this a normal cell or is this foreign? Does this have a virus infected it or is it cancerous? And one of the things that cancers, one of the ways that your body prevents autoimmunity is it's got built brakes or checkpoints on this. So this molecule right here is called PD-1. So you might keep hearing about PD-1 inhibitors. This molecule sends signals saying don't activate to the T cell. And if it sees this molecule PD-L1 on the tumor cell, binding it, that engages it and sends that signal. So by using a drug that blocks either PD-1, as shown here, or blocks the other molecule, the one the tumor cell expresses called PD-L1, we can take the brakes off the system. So inhibit the immune checkpoint and let this T cell that recognizes this as foreign attack it. So this is an important mechanism to prevent autoimmunity, but it's only one of many important mechanisms, and the tumors have taken advantage of this to hide from the immune system. And so there's, in some subset of patients with colorectal cancer, you'll hear about sort of mismatch repair. And this only makes up about 5% of metastatic patients. It's much more common in earlier stages of cancer. But these patients respond really well to these immune checkpoint inhibitors. They probably have a lot of mutations throughout their cancer that are recognized by the immune system. And so that's what's on this graph. This is the higher you go, is the chance of surviving longer. And this is length of time out from treatment. So you can see the patients, all these patients were treated with immune checkpoint inhibitors. And if you had intact mismatch repair proteins, you didn't do so well. Many of those patients died off early. If you had mismatch repair deficient cancer, so it had disruptions in these genes, they did much better. And so one of the questions is, why is it not working for these patients? Which is about 95% of patients that are with metastatic disease are going to be in this realm. So these are where we really need to do some work. And how can we move that curve up there? So how can we make the immune system recognize these cancers? And so one of the ideas is to use radiation to help this happen. So radiation has a lot of effects on the tumor. You cause DNA damage in the tumor, particularly in the liver, where we do these very high dose ablative treatments. We're killing a lot of cancer cells. There's a lot of foreign portions of the tumor that are being expressed. There's some new gene expression of other things that can be recognized as foreign by the body in response to radiation. The dying cells also cause the release of inflammatory, what are called cytokines. These are sort of ways that the immune system communicates. But it's just, the take home from this is it's a very inflammatory environment. And the other thing I think that's really actually important is that radiation is probably removing immunosuppressive cells. So you have subsites of your immune system that actually are suppressive, so specialized T cells that do the exact opposite of the ones that we were just talking about, that suppress responses. And radiation can kill some of those cells. So one of the things that Dusty and I have going is a clinical trial that's supported by Merck, who makes one of these immune checkpoint inhibitors called pembrolizumab. But it's combining this stereotactic radiation, that we call SBRT. So these very high dose focal treatments to patients with tumors in the liver. And one of the things that's unique about this is that patients have to have disease that can be completely resected in the liver. So even though that's causes good outcomes for a subset of patients who are able to get all their disease in the liver resected, there's still about 60% of those patients or slightly higher that will recur with time. Half of those patients roughly within a year will recur, and then over the next year, another subset. And so for patients that have liver resectable disease, we wanted to, before they got that disease removed, give radiation to one of those tumors to try and provoke an immune response, and give one of these immune checkpoint inhibitors to try and stimulate an immune response, and at the point where we're removing all the rest of the disease, so that any microscopic cells elsewhere, hopefully your immune system can clean up before somebody has a recurrence. So that's the premise of the trial. So the way this goes is patients who have metastatic disease that's confined to the liver and who all their disease can be resected at the time of a surgery. So you can have a primary cancer still if we're planning to resect that and your liver disease. But you can't have metastasis elsewhere, just to the liver for the primary. They can undergo whatever therapies they've undergone beforehand. And then if there are candidates for clearance of all their sites of disease in one operation, and we can do safely radiation in that very high aggressive dose to the liver, like I showed you, we will enroll them on this trial. Again, they have to have microsatellite stable disease, so they can't be one of the good candidates. So they would undergo radiation from 1 to 3 of their liver lesions, and then after they're done with that radiation. So that radiation, instead of taking 6 weeks, is done over the course of about 10 days, within 2 weeks. 5 treatments. Then they'd undergo a dose of this immune checkpoint inhibitor called carbone 2 weeks after that, and then go to surgery 2 weeks after that. And then they would continue on with the immune checkpoint inhibitor after that. And our hope is to see that we can increase that time until progression, or increase the number of patients who don't subsequently have progression. One of the
Did you say MSS patients, not MSI?
MSS, yeah. Yeah, and that's going to be the majority of patients who are in this situation.
Yes, just-
If there were MSI, we probably would just give them the immunotherapy and,
Right.
and not the rest of the treatment.
So why do they have to have resectable?
Yeah, so it's a very good question. So one of the reasons is that in preclinical data, it suggests that other tumors remaining can help suppress a systemic immune response. So those suppressive cells that I talked about within other tumors potentially could suppress the response. So it's a situation of trying to stack the deck in as much in favor of an immune response as we can, and use the immunotherapy really to kill any microscopic disease that we can't see. If they can get surgical resection, we can take care of all the gross disease, and we should. But how do we increase the number of patients that do well after this? And so that's really the hope of this. The other really nice thing about radiating a subset of lesions is now we can take that tissue and we can compare the patients we have both the radiated and unirradiated lesions. And Dusty can take a look at this in the lab afterwards and say, what's the difference between the tumor that was irradiated and wasn't irradiated in these patients that got this immune checkpoint inhibitor? Is there a better response going on in the radiated lesion than the other areas? Has the response spread from the irradiated lesion to the other tumor? So there's a lot of sort of correlative science behind this that hopefully will help us understand why some patients are responding, or why are microsatellite stable responding, but these patients microsatellite unstable responding, but these patients with stable microsatellites are not responding.
Can we actually look at mouse livers?
That's a good question. So there are irradiators that will let us irradiate the mouse liver. There's a lot of, I think we are potentially getting one of those irradiators. And so if that, most mouse radiation is done by just a single source that comes down from the top, and we cover the mouse with lead and treat sort of through and through one section, this implanted tumor in the skin. But it's not a very realistic situation. So there's certainly interest in doing exactly that with these more specialized mouse radiators. But it's hard enough hitting a big tumor in a patient that's compliant with a mouse. It's even tougher at this point. But yeah, that's really a question. It'd be great to work out the science in mice if we could too. So the other thing that's going along with this, and one of the specialties that the University of Wisconsin has, is the strength of the radiology program here is fantastic. And so these patients are getting a PET MRI that Dr. Kim has worked on protocoling. So that PET MRI that he showed you at the end of his presentation, these patients are going to get that before radiation, after radiation, and then after their immunotherapy, but before their surgery. Along with that, a subset of the patients are going to get a specialized type of a PET scan called an FLT PET scan. And so that tells us, instead of metabolic activity, that tells us about proliferation of cells. So our hope with this is that through the combination of these imaging modalities, we can also learn something about the immune response happening in the patient. I'm going to show this picture from another paper that was published from a group outside that was looking at a melanoma patient who received a different type of immune checkpoint inhibitor. and they had a lesion on the top of their scalp that was metabolically active with FLT PET and a little bit with FDG PET, a standard PET. So this is the standard PET here. This is that specialized type of PET scan. But they also had noticed that there wasn't any metabolic activity in one of the draining lymph nodes from this. And cancer can spread to lymph nodes, but usually that would show up with metabolic activity here. But your own immune response actually lives in the lymph nodes. So T cells live in the lymph nodes. And so what they saw was after this treatment, with immune checkpoint inhibitor, the tumor went away and the metabolic activity went away from the top. But the lymph node that drains this all of a sudden became very metabolically active and proliferatively reactive. And this turned out to be a T cell response actually happening against the tumor. So one of the hopes is that with this very early time frame, we catch the T cell response going on at that time. One of the issues is we don't know when to give the immunotherapy. Should we give it before radiation? Should we give it after radiation? Should we give it somewhere in that time frame? And hopefully with more study, we can figure out what the optimal time frame for that is. So there's a lot of questions out here, and hopefully we'll learn something from this trial.
So where are you on the clinical trial?
It's enrolling patients, so we've enrolled patients. It's still at the beginnings of it, so it really just opened a month and a half ago, I think.
Is it just being done here, or is it
Just being done here. So the main point of this trial is safety. These treatments haven't been combined together, and so it's a phase 1 trial. So that's really what I wanted to present today. So I think radiation does play an important role in colorectal cancer patients. It's a little bit more situated. Not every colorectal cancer patient will need radiation or receive it. I think MRI guidance may improve the role and the quality of radiation. So hopefully we are mitigating some of the side effects that happen with radiation. And then the other thing I'm really hopeful for is that being able to follow patients with inter-treatment response during treatment at the time when we can actually do something about it is important. And this may give us the data to decide when to do a more high-quality scan mid-treatment. But I think it's going to have a lot of information about which patients are responding, which patients aren't during treatment. And if we can correlate that to how their long-term outcomes are, we may learn something. And then the other thing I just wanted to let you know is just the exciting research that was going on here at UW-Madison. I think Dusty's been a huge proponent for colorectal cancer patients here. It's gotten me very engaged, and with some of these new agents like immunotherapies, I think there's a lot of potential for better outcomes for many patients in the future. And then this is my department. There's a lot that goes on behind the scenes with radiation that most people don't realize. It's complex technology. It can be beneficial and it can be harmful, and doing it well takes a big team to make certain that happens. Yeah.
Is it possible to look up these trials and read them?
Yeah, so any clinical trial is on clinicaltrial.gov.
Oh.
Some of you guys probably have been to that site and should give a description of the trials. So certainly that's where I will go if I'm looking for, hey, are there any trials sort of in a certain area?
Thank you.
Yeah.
Well, I've seen that Pembro is being used potentially for a lot of different types of cancer.
Yeah.
Is this going to be like the magic bullet that can cure? And out of curiosity, if you get Pembro for one type of cancer, will that tend to engage your immune system enough that it will potentially prevent other types of cancer? Because I guess we're more inclined to get other types of cancer because we had
Right.
CRC.
That's a really good question. The last one's a really good question that I don't know the answer to. I think that's possible that that's the case. We think that the immune system actually screens out precancerous lesions all the time, and that we're just not aware of that. There's some evidence from mouse models of that. It's not the magic bullet. It may be. I think it's an advance, and for some patients it's going to be fantastic, but alone it's not going to work, and we know it doesn't work for the majority of patients. Combining multiple immune checkpoint inhibitors seems to do better, and particularly in melanoma, that's borne out. And we're looking at that in other disease sites like lung cancer. Combining this type of therapy with other therapies, there's some conventional chemotherapy or targeted drugs that seem to make this potentially work better in colon cancer patients who have microsatellite stable disease as well. at least very early stage evidence of that. And so it's going to be these combinations. The immune system, this is just another diagram of a T cell. I showed you PD-1. So on this side of the diagram is all the things that stimulate a T cell. There's all these sort of other engaging receptors. And on this, all the ones that inhibit. You can see there's a lot of different potentially brakes on the immune system. And I think that there'll be other treatments that target those brakes. They're already in preclinical trials. And probably the combination of some of these will increase the efficacy in some patients, and it will probably increase the side effects and toxicity. And I think it's a big step forward. In fact, I think it's a huge step forward, but it's not going to be the magic bullet that gets rid of all situations.
I'm a radiologist and an oncologist and immunologist. And so what we were going to do, we are going to do a tour, hopefully. But one of the other presenters is here, and he's going to be, he needs to leave by 11. So this is what I was thinking. What does your schedule look like?
Do you want to do the tour at 11 or break?
Yeah, is that okay with
Yep.
you? Okay, so here's what I'm thinking. I'm sure everyone probably needs to get up and move a little bit. So if you guys could be back here like at 10:30 straight up, or straight down, I should say. 10:30. So if you guys can be back here, and so that way we give Sam at least 30 minutes for his presentation and some good time for you guys to interact, because it sounds like there's some super exciting stuff. So 10:30, grab a banana. This is all food that's going to go to Dusty's lab if you guys probably don't eat it. So go ahead and help yourself to anything, because we will be doing lunch and having a lot of really good time for interaction. But we're going to be closing shop around 2:30 today. So a lot of food. Awesome job. Thank you again. Yay. So 10:30, we'll see you guys shortly.
So then lunch is being moved back to?
I don't really know yet, Liz. We'll work on
It'll
that.
be coming in,
Okay.
so it'll be here when you get back to the tour.
That's exactly what's
Being in medical education, I have to have an objective slide. I should have had my disclosure slide too. The only real disclosure I have is I am a one-share owner of the Green Bay Packers. So, Lombardi Middle School, if anybody wants to know, I know there's at least one Bronco fan in the house today. I'm sorry about last night. So, I truly am. I was actually cheering for the Broncos last night because those uniforms were awesome.
We lost because of those orange pants.
My cancer, there's a Lombardi Cancer Center.
Fantastic. I went to Lombardi Middle School.
Yes.
So the middle schools in Green Bay are all named for prominent and outstanding Americans: Washington, Jefferson, Edison, Franklin, and Lombardi. So it really goes deep. So the objectives of the next few minutes for me are to help you guys understand the concept of clinical trials and when we say a phase 1, phase 2, phase 3, what does that mean? What are the numbers involved? What are the endpoints? And understand why cooperative groups are absolutely vital for really any disease types, specifically colorectal cancer, as we're trying to figure out, is it one big disease or is it multiple little diseases based on molecular subtyping? Are you a lumper or a splitter as a history major would be what we would call that. And then bemoan why it takes so damn much time and money to answer what seems to be a relatively simple question. Does drug X work? The fact that that is such a hard question to answer is partly why we're all here together trying to figure this out. So why does it matter? Currently, if you look at different publications, this one is from the Journal of Clinical Oncology, it's estimated to cost about $1.2 billion to successfully bring a compound from design to market. And most drugs fail. The number of sort of compounds that start off with potentially therapeutic intent that end up actually being approved by the FDA for a specific indication is on the order of 2%. And that's probably an overly optimistic estimate. The cost of failure in this wilderness is incredibly high, both in terms of finances, but also in terms of patients. If you have a drug that fails, that ultimately has no benefit, what happens to all of the patients who were exposed to that drug? Hopefully it wasn't harmful, but we don't know. So it takes about 8 years for a drug, I'm not even talking about the preclinical development. From an idea to phase 1 probably takes a decade. But from a phase 1 trial, which I'll explain in a second, to actual FDA approval takes about 8 years. There are some exceptions, there's some fast tracking that we'll talk about. Now, so Otto von Bismarck is not often included in academic discussions, but he had a great line which was, you never want to see laws or sausage get made. Right? I would also argue that clinical trials in medical science is also a process that's sort of dirty and a little sausage-like. You don't really want to know what's in it. You want to know the end result. So how do we decide what works? This is a messy process. It starts with an idea. It starts with Dusty in his lab with some spheroids, squirting stuff on them and saying, hey, do these make the cells die? And then we do this high throughput screening. So if we have access to dozens or hundreds of compounds, we have cells in a dish, we can start to analyze through high throughput screening, basically a very fancy way of testing a bunch of in vitro cells all at once. What makes them die? What makes those cells go away? And then animal models are a little bit better because then it starts taking some of the variability of normal tissue in play. So Dusty's animal models are really important things, as are the sort of spheroid cultures, trying to figure out how these cancers behave not just in a dish, but in a living thing. We can't realistically do these experiments on humans. The risk is too great and you'll see how some of the experiments that we do in phase 1 clinical trials are scary and potentially very unsafe. But at least in that process of informed consent, we can explain a little bit better about what that is. We have tons of improvements in the area of animal modeling so we can do more preclinical work before we expose patients to potentially toxic compounds, but we have a ton more work to do. So these are my 3 children. Ben is 5, John is 4, and Mary is 1. And if I want them to do anything or learn anything, it has to be in the form of a story. So I have to tell you guys a little bit of a story to walk through this. Ripped from the headlines, right? We all were around when Law and Order was on. And in fact, right around the time that Law and Order was a show in 1990, actually I had to look that up, was around the time that the inhibition of epidermal growth factor receptor was found to be possible. So in a lab in Israel, this compound got synthesized. Now, there is a ton of the backstory behind this drug that became cetuximab. Who's had cetuximab in the room? Anybody? Okay, so how this drug got developed is a sausage. Okay, this is totally weird and disgusting as to how this thing came from this lab in Israel to people, to actual benefit. And I think this is particularly illustrative of the process. The two people who were in this lab actually got into a very nasty intellectual property lawsuit as to who actually came up with it. So the guy who came up with the idea of blocking EGFR called this other guy and said, do you have any compounds that block this pathway? And so that was where the fight came in, and you'll see why. So phase 1 clinical trials. Once you have the idea of a pathway and you have a drug to hit a pathway, you have to figure out how do I give that drug to people? Phase 1 clinical trials are dose finding. There is no endpoint of efficacy in a phase 1 clinical trial. There is no expectation of improved survival in a phase 1 clinical trial. That's really scary. But it has to be included in the consent process for patients to say, I am giving you access to this drug. It works in a dish. We don't know the dose or the schedule. That's why we're doing this trial. So the way it starts is at what's called the LD10, the lethal dose for 10% of the animals. Yikes. That's the starting dose, and then we escalate up from there. That's really scary. However, this is the kind of thing that we believe to be safe and why the phase 1 trial is necessary to get to escalating to a dose that we believe to be therapeutically effective. So a traditional phase 1 study is for patients with refractory solid tumors, a very unselected population, people with cancer that has progressed through stuff that's available. However, there are folks who are still feeling okay after that process and really giving of themselves. I really think my patients who are on phase 1 trials give such a tremendous gift to the rest of us, all of us, that I am willing to stand up and say, go ahead, try it on me. It is a high risk, high reward for patients because the potential reward is if you're in that lucky percent where it works, there is nobody else in the world who can get access to this compound. Many of these compounds are known by a series of numbers and letters. IMC225 in the case of cetuximab. MK3475 for Pembro, is that what it was? Yeah. So, and you'll often hear, by the way, particularly nerdy oncologists use the numbers and letters to be like, I was there, it would still be D16, you know, like, it's like a band and hipster thing. So the endpoints are really toxicity. When do people have a significant dose-limiting toxicity? When does the rash get so bad that we can't go higher on the dose? When do they have bone marrow toxicity? Or God forbid, when does somebody die? And so this is all open label. There is no randomization. There is no placebo arm. This is, we know what you're getting. We think this is the right schedule to give it. And that's how a phase 1 trial works. Classical 3+3 design is basically you enroll 3 patients at a time at a dose level and see if they have toxic side effects. If one patient has a toxic side effect, you expand the cohort to another 3. And if another patient has a toxic side effect, you have basically a third chance of having something very significant happen. That's the maximum tolerated dose. If, however, you have no toxic responses, you can go up to the next dose, and then you keep going, following this algorithm to get to what's called the maximum tolerated dose. Does that make sense? Mm-hmm. So it is really it is a true experiment in the truest form, saying, I'm going to give this to you and see what happens. What does success look like in a phase 1 clinical trial? Really, success looks like you have a dose that's biologically plausible. in the in vitro studies or in the mouse models, what was the dose that it took to make a tumor do something that made you want to test it? Can we get to those levels in people? And what happens to them when we get there? Is it biologically plausible to move this drug down the road? Did anybody respond? And the crazy part is, a historical response rate for a phase 1 trial is 5%. So almost every center looks back at their phase 1 experience and says, how many responses have we had over the last decade? Almost every academic center that has a phase 1 program has a response rate of around 5%. One of the key things that we want to look for is, how can we design trials better and pick patients better for these targeted therapies to improve that response rate? Okay, so what happened with cetuximab? So IMC-225 showed 2 responses in 13 patients. That was enough to move on and to get published in our big journal, Journal of Clinical Oncology. The swimsuit edition of that is terrible. But so based on the responses that were shown in that clinical trial, because Dusty and I are in it, it's not that good. But 2 responses out of 13 was enough to have, sort of a slow clap at a national meeting and say, hey, let's expand this cohort to head and neck cancer and colorectal cancer. So now that we have a dose and a schedule, how do we determine success? We look for objective response rates. We look for tumor shrinkage on scans. That requires more patients. We can't just do this with 13 patients. So a typical phase 2 trial is somewhere between 40 and 100 patients. It is very often open label with no randomization. Sometimes we give it with existing therapy. Sometimes we do randomize. A randomized phase 2 trial has the drug that you're interested in plus either a control arm of what's already out there or the drug you're interested in plus another drug. Does that make sense? These still are typically late-line, heavily pretreated patients. A randomized phase 2 trial in the first-line setting is a dangerous thing because you don't know how well it works. And if you're moving it in front of stuff that we already know works, that's a very dangerous proposition, and you better be double damn sure that that's going to do something. So the endpoints that we look at for a phase 2 trial are response rates. What percentage of patients have tumor shrinkage? Progression-free survival. How long does it take for patients to have their tumors grow beyond a certain threshold? Or a disease control rate. How many patients have stable disease? So a home run, and since it's baseball season, I want to put Carlton Fisk back up there. So a home run would be, in a heavily pretreated population, having anything more than a few percent of patients have tumors shrink. And so what that means is, if you have a real home run where everybody responds, you can get accelerated approval from the FDA through a phase 2 study. That is vanishingly rare, but possible. So then after you have a successful phase 2 study, you can start thinking about other trials to get this drug incorporated into clinical practice. Now, in a heavily pretreated population, 9% of patients with EGFR overexpressing colon cancer responded. That's a big deal. There was tons of excitement in the community. 60 Minutes did a piece on it in 2001 advocating for all colorectal cancer patients to get access to cetuximab in 2001. And this was thought to get FDA approval on a fast-track basis. Tons of people investing in a company called ImClone, which is what IMC-225 made. So again, another real exciting and lots of enthusiasm for that. However, the confirmatory studies weren't there. FDA approval was held up. Investors in ImClone lost a lot of money. Martha Stewart went to jail for cetuximab. I forget, Dusty, do you remember this story? I think it was her son-in-law or something like that was an executive at ImClone and leaked to her the fact that the FDA was not going to approve cetuximab, so she sold. 3 days later, the FDA said, we're not approving this drug. Stocks of ImClone crashed. And remarkably, however, and so that's why Martha went to jail. That was the insider trading from ImClone. The only thing that ImClone made was cetuximab. That was its only revenue stream. Remarkably, however, the drug didn't die then because it still had an indication in head and neck cancer, and it still in colon cancer worked in a subset of people. Why did it work in that subset of people? And that's where the science comes in. in the 5 patients who responded, what was unique about them? Why didn't the other 52 respond? So really understanding this pathway, how blocking the epidermal growth factor leads to a signaling cascade that says cancer cell grow. What we learned, and I think something that most of us are familiar with now, is we can block up here till the cows come home, but if this KRAS mutation is present, or a BRAF mutation is present, you can block up here all day, but this signal is still going to go to the nucleus to say, divide cancer cell. Does that make sense?
Yeah.
So once that was teased out, they went back to the drawing board to say, hey, maybe we can use this not just in EGFR overexpressing cancers, but in folks who are absent a RAS or a RAF mutation. So that's where the next set of studies came through, and it actually showed a survival benefit in pre-treated patients. And in second-line therapy, cetuximab got FDA approval in 2004. Now, there's a sign outside of Dusty's lab. One of his lab techs has, do all the things. So she's a very enthusiastic person. And this really underscores what happens with a drug that gets approved. Now it's like, let's test it for everything. Let's look for every possible avenue in which we can use this drug. Not only from an altruistic perspective, is there patient outcomes on the line? There is a ton of money on the line. And for us, the patient outcomes mean something, but for the people who invested $800 million in developing the drug, they want to reap some of that benefit. So then we have to go to phase 3 studies. So after showing safety and efficacy, phase 1, safety, phase 2, efficacy, now phase 3 has to show improvements when compared to that which is already out there. Does that make sense? So that takes hundreds of patients, and that requires blinding and randomization. We can't know who's getting drug X. Because if we knew that, and as investigators we had some implicit bias to say, I want drug X to work, it's not a failing more than it is just us being humans. We want these things to work. So to avoid bias, it takes blinding and randomization. Being on a phase 3 trial doesn't mean you get exposure to drug X. This is a high-risk, high-reward proposition, not for the patients really anymore, because the safety and efficacy have already been worked out. The risk-reward proposition now is for companies, because this requires millions of dollars of investment. Requires a ton of regulatory oversight. The institutional review board, is this safe? Is this ethical? Data safety monitoring, who is responsible for deciding what a response is or isn't? And it has to be protocol driven. We have to be able to treat patients the same way here that they will in DC, that they will in Colorado, that they will in Seattle, that they will in New York. Does that make sense? So creating the recipe that goes in the cookbook. Typically this is at least sponsored by companies, but a real gold standard is when it's done by a neutral party. Having a governmental institution run this with no skin in the game other than the well-being of the populace. So if you see a phase 3 clinical trial that is entirely funded by a company, there is some skepticism that creeps in there. So the design options, we have to first design who is the population. The drug cetuximab failed when we took all patients with colon cancer. It succeeded when we said patients with KRAS wild type tumors with no mutation that will say it's not going to work. And then we have sort of a control arm, which would be standard chemotherapy. And then the treatment arm, which is chemotherapy plus cetuximab. Makes sense? And then the other questions are, is the randomization ethical? Do we do a 2-to-1 randomization to get more people access to the drug? Complete the study faster, but it costs more money to do that. Do we offer crossover? If it works for the people who were on the placebo arm, do they get access to the drug at the conclusion of the study? Wow, so some very complicated questions go into clinical trial design. So the brass tacks endpoints are, does this drug make people live longer? I don't care as much if it makes studies prettier, if it makes a CAT scan look nicer down the road. I want to know, is this going to make my patient live longer? There's a ton of safety data because in this large population, this is where the rare side effects come out. So all these commercials about talk to your doctor about, those all come out of phase 3 clinical trials. The side effects that were reported in the phase 3 clinical trials are the ones that get reported on the commercials with the bathtubs. P.S. The fact that we're spending billions of dollars a year on that particular medication versus cancer drives me nuts. The fact that I can't watch an NFL game without my 5-year-old saying, "Daddy, what's a reptile dysfunction?" Crocodile that is ineffective. That's all it is. To complete the story, and sadly it's true, he's in kindergarten, and it's like, oh, okay, Benny. So phase 3 clinical trial, these are examples of phase 3 clinical trials for cetuximab. So Crystal, FOLFIRI plus cetuximab in KRAS wild-type patients. Response rate's 59.3%, so a 10% improvement over FOLFIRI alone. Wait a minute, I thought this was a home run drug. We're talking about response rates that are only a little bit better. Overall survival improvement of 3 months? Is that really a home run? Well, I kind of think so. COIN, response rates improved, but overall survival wasn't really changed. BOND 2, using cetuximab plus Avastin. Anybody take Avastin? Have you been on Avastin? Yeah, okay. So using cetuximab and Avastin in combination, response rates less, toxicity higher, death sooner. Yeah. What? So using these two drugs that thought, there was an editorial in 2000 about Avastin saying the end of cancer, the magic bullet, right?
Saved my life.
Yeah, well, and Avastin's a hell of a good drug. Yeah. But when used in combination with other drugs, it doesn't play well. And then this study, the adjuvant study, PEDAC 8, addition of cetuximab did not improve disease-free survival. Now, look at all of these patients. So I did some math. If it costs $25,000 per patient to be on a clinical trial, which is a pretty reasonable number for all the regulatory oversight and all the process, 6,142 patients in these 4 studies. Now, there were dozens more. But this, conservatively, is an outlay of $153 million for those 4 studies. And, so high risk, high reward proposition. So the design of trials means something. And then throw into this that around 2004, 2005, Amgen came out with panitumumab, a humanized version of cetuximab. Dosing it every other week costs 2 to 3 times as much. Similarly confusing results were seen. Improvements in survival in some studies, not in others. So after all that, thousands of patients exposed to this drug. Eli Lilly bought ImClone and its only compound, which was cetuximab, and then what turned into ramucirumab, which is now in clinical trials, for $6.5 billion. Holy crap. So what did we really learn? That targeting EGFR is possible, safe, and does improve overall survival in patients with metastatic colon cancer, as long as they don't have a mutation in KRAS. So there were some surprising findings that why didn't it work in the adjuvant setting? Why didn't it work in the no evidence of disease setting? We still don't know that answer. So we have learned that response rates are better with cetuximab the sooner we use it. However, we don't have a significant overall survival change relative to whether we start with Avastin or cetuximab. There are other mutations besides KRAS that mean something, all of these other RASs, and responses are great things, but they're not the cure. The drug works for a long time, but it's not going to eradicate the cancer from people's bodies. All right, so why does that matter? I think when you guys are out there reviewing studies as patient advocates and things like that, you have to ask, is the question valid? Will the study answer the question? And is the study worth the risk to patients? Is it worth the risk to society? You don't really need to care if it's worth it to the company. The company's going to fund this. But the bigger question is, do we benefit from a scarce resource? Do enough patients benefit from this to put those 6,000 or whatever patients potentially in harm's way? So these questions are critically important. And the slides, by the way, I sent out so you can get those. You don't need no slide. So cooperative group studies are critical. We don't have 6,000 patients with colon cancer that walk through the Carbone Cancer Center anymore. We couldn't accomplish this study alone. So ECOG Akron is one group that we're a part of. We helped found it here, actually. So both academic and private practice groups around the country are members of ECOG who can enroll patients on these trials to increase the N. SWOG is another group, Southwestern Oncology Group. There's the new Big Ten Cancer Research Consortium. So we're really trying to get that up and off the ground to improve our numbers, to get more people exposure to the science that we do. Cooperative groups have great advantages. You can get access to tons of patients, and once the sites are open, you can accrue relatively quickly. The investigators themselves are typically well respected. Being at the university of something you've heard of gives you a chance to present the data and say, oh yeah, this is Mike Bassetti's study. He's not some schlock. I know him. He's devastatingly handsome too. He just walked in the door. Leveraging the strength of different institutions, saying, hey look, Michigan has great radiation oncology. Wisconsin has great radiology and medical oncology. How can we bring these strengths together? So maybe they bring radiation oncology techniques from Michigan. Maybe we do a central review of the imaging studies here. So we can take the best of each institution in a cooperative group and put it together. And we can ensure protocol adherence. If everybody's reading from the same playbook, written the same way, with the same group reviewing the data, we can say this is a standard population. This reflects the population as a whole. Does that make sense? So disadvantages. This is slow to design and open. Sometimes practice isn't uniform. Sometimes people have their way of doing things. God forbid oncologists be sort of stiff-necked group of people. And it takes a ton of staffing to get it right. I'm glad Renee just walked in when I can say that it takes a ton of people to get a clinical trial up and running the right way. So how it works, this is really where the sausage part comes through as well, that ideas from investigators go through a steering committee, a national body of esteemed clinicians to say, this is how we want to do this. And then the steering committee says, yeah, we want to move this forward because this is an outlay of time, money, and patience. And to have it sort of willy-nilly, to have somebody just throw an idea out there and see if it sticks, there has to be more to it than that. The idea needs a sponsor. Who's going to supply the drug? Who's going to pay for the actual science? Who's going to help Dusty's lab do more mouse colonoscopies? And furthermore, who's going to help make sure that the data is safe, secure, and that the study's done in a patient-centered and safe way? So once the go-ahead is achieved, it seems like a no-brainer that everybody involved in the cooperative group wants to be involved. But sometimes, well, you know what? We don't have enough of that population, so we're not going to open it here or there. And then once accrual is complete, the findings are presented and published. Natalia and I get job security because we've presented this great study, and now we get to pay for my season tickets for the badges. What about this moonshot thing? What is the Cancer Moonshot Initiative? So a lot of it has to do, and I wanted to put this slide from The Onion because I just love how they've turned Joe Biden into like everybody's creepy uncle. He's really not that. He's not the guy washing the Trans Am in the front yard of the White House, but it's sort of an awesome picture. The idea behind the moonshot that Joe is pioneering, largely because of his son's death from cancer, is to try to decrease the burdens of infrastructure. To try to say, look, if somebody has a really good idea, how can we move that faster? How can we get that further down the line without all the administrative hurdles while still being safe? So I think stay tuned for that, because I think the goal is to make our discoveries faster at a lower cost. But the hard part is, this is complicated stuff, right? I mean, this is just one set of pathways. There are dozens more that play into oncogenesis. So that's why it takes all these clinical trials to answer these seemingly simple questions of, does this drug work? I'll stop there. And the sad part is the reason I have to leave is because I have to go to a funeral. One of my patients who had esophageal cancer for 6 years, after all of that, he died. And I want to stop wearing black suits. I don't want to do this anymore. So anything we can do to keep that from happening, I'm on board.
Sam, when does a patient know that it's a good time to go on a clinical trial?
I think a couple of points. One is when you start going off a paved road, right? For colon cancer, we have a pretty good paved road of either FOLFOX, then FOLFIRI, or FOLFIRI, then FOLFOX. And then mutational status will help dictate either cetuximab or Avastin. And right now, I mean, those drugs were pioneered and presented in 2004. We have not had anything come close to beating that in 12 years. So when there's something that has generated a lot of enthusiasm in an early phase, there's a buzz about it, like there was with cetuximab early on. And so when folks are running low on options, start thinking about, okay, first line therapy failed. Anytime therapy fails, it's time to look around for all options. Standard therapy, clinical trials. At initial diagnosis, same thing. Yeah.
Quick question. If accrual takes so long for some clinical trials, and you get a patient who joins that trial early on versus the patient who joins the trial a year into the accrual, doesn't that first patient get more of the advantage of taking that? I mean,
What if, in the dose escalation, the first patient gets a dose that's subtherapeutic?
I don't know.
Yeah, so I think
I'm
being...
just thinking, so doesn't that skew results?
No, and I think that's why they're protocol driven. We can't, what becomes a challenge in clinical trial enrollment is if that first patient does really well and 60 Minutes is out there with a camera saying, look at how good this person did, everybody else is gonna say, forget the trial, where can I buy the drug? Where can I get this off label? And then the trial can't accrue because people are getting this stuff from other sources. That's why it's so important to have a trial and stick to it. And in our practice, we try to really minimize off-label use as much as we can. And why Dusty's molecular tumor board is such an important thing to say, if we're doing that, we better have a damn good reason why, and we better be studying the outcomes. Does that make sense?
Yeah.
So if you're the first patient on the home run drug, you will ultimately get the same benefit because the dose isn't going to be all that much different. But what may end up happening is other patients may not be able to get on study if it works too well.
Or if other patients don't have that success, how does that, I mean?
Well, then we start figuring out why did it work or why didn't it.
Okay, all right, thank you.
So to what extent does competitiveness, among these various research centers and the desire to monetize the discoveries impede the formation of these cooperative groups and the operation of these cooperative groups?
Totally right. And I think the nice part is working at a state hospital that is entitled not-for-profit means that we don't actually get financial benefit from the trials that we run.
Well, I was at a meeting where Johns Hopkins was doing the presentation, and two of the Johns Hopkins people had just left Johns Hopkins to form a company to commercialize something that they had discovered while they're at Johns Hopkins. So
yeah, absolutely. I mean, I think in that sense, that building right there is the Wisconsin Alumni Research Foundation, Warfarin, Wisconsin Alumni Research Foundation, Erin. That's where it got discovered, and that's how it got monetized. 5 cents a pill helped build that hospital one brick at a time. So, and that's another cool story, but I don't have time. But the point of it is, yeah, if somebody makes the initial discovery, those two scientists in Israel got in a multi-million-dollar lawsuit because there were billions on the line.
because it seems to me there are so many clinical trials going on, that there has to be a lot of duplication, even a lot of duplication of lab studies before you get to clinical trials. And wouldn't it be great if there was some way to, make all that known? For you to present at ASCO or to write a paper for a journal takes a lot of time.
Yep.
Even to get accepted.
Yep.
And so how widely disseminated all those results, especially failures.
Totally right, exactly. And I think part of it is that the investigators are directly invested in, and I think a truly altruistic way, I hope, the success and failure of their ideas and the patients, not, I want this to work because I'm stubborn.